private health sector assessment, itu nanti akan dari Mbak Ibu Sita juga. Kemudian nanti akan ada juga speaker dari Indonesia, yaitu Profesor Adi Utarini. Lalu juga ada dari Hong Kong, yaitu Profesor Chi Tim Hung, mohon maaf saya bingung cara membacanya, dan itu nanti akan membahas terkait dengan external quality assurance and accreditation gitu ya. Setelah itu kita akan ada tea break, jadi mohon harapannya nanti setelah tea break, mungkin di saat kami break, kayak Bapak Ibu ingin break, persilakan.
Good morning, everyone. Welcome back to our policy course. So we have our Shatin to do the summary for the last day first, and then she will have the private sector health assessment session. Okay, Shatin, please.
Ya, Bapak Ibu, kita akan mulai saat ini. Terima kasih. Saya akan sampaikan progresnya lewat kolom chat.
Hey everybody, for your attendance this morning. I see some people are still missing, but I hope they will be here very soon. Right. Okay, I'm going to remove this because I'm on the phone. So I do. This is my. So my name is Lisa, and I'm going to give you the summary of last day. Yesterday we have a very busy day. I hope that you still remember some points from yesterday's session. I'm going to talk about first when in the morning Professor Ike gave us the introduction to the course and to the framework. He basically reminded us of why do we need to have an integrated system. So he talked about that the health system is very much fragmented, as you can see from the experience from different countries in the panel. You can see that this fragmentation happened at different levels and different facilities, and that he introduce us to the idea of the current advocate for having an integrated health system, to have a person-centered or people-centered health system, and that it needs to be a primary lab care. And this integration can happen horizontally among facilities at the same level, or it can happen vertically, among different level of facility. And there are some modalities and mechanisms for such. This integration also happens between the public and the private provider. Next, and then he introduced us to the framework that the ANHSS is using. This framework was developed back in 2019, but this was a very evolved framework from the basic private sector engagement framework that was developed even years before that by Harding, and also Precker, Alexander Precker. So the framework starts with us needing to look at what are still lacking in whether it is a question of the universal health coverage, whether it's a question about issues on equity, quality, and support, or whether it's a questions about us not meeting some of the national priorities. So integration of services or any kind of reform in that matter should start with some kind of health system goals in mind. So that's the starting point. And then when you wanted to do integration of services, when you wanted to engage the private sector, then you need to understand them. And through doing the assessment, you will be having more understanding of your private sector and also parts of the public sector, of course. And then you look at some of the policy instruments that you can use to do this integration. You can use different kind of policy instrument there, governance, financing, and so on and so forth. And then those instruments will enable the modalities and the mechanism that you're going to use for integration, whether you want to have an organizational integration or you want to do a functional integration. These are enabled or inhibited by the policy instruments that you use. And hopefully, with the comprehensive designs that you already have, then you're going to implement them, and you also need to monitor them, of course. So these are the topics that we are going to cover in this course, and each topic will be, and each box here, if you will be covered by different sessions throughout the course. We also hear from our panel about the challenges in the primary care. We look at the fact that the services are very much fragmented again, and that is not much well implemented in some area more than the others. So for instance, on mental health, on rehabilitative care, is still very lacking of attention. And that sometimes we also lack of resources available for primary care. But even when there is availability of human resource for health, it does not mean that's not equally means that they are providing quality of services. And in some countries, some payment mechanism for private healthcare does not incentivize performance. So there are still questions about quality and performance that are being delivered at the private and at the public sector. Again, in a mixed health system, a lot of the burden of service still relies on the public sector. And there is a common theme of difficulty in engaging the private sector. So with that in mind, Professor Ike mentioned about introduce us about the framework for integration, looking at the importance of using a policy on the health system at the macro level in order to mobilize the resources that we have at the meso level, which is the provider organization level, and at the micro level, which is the clinical level. But these policies and modalities and mechanisms are interdependent, and it needs a capacity to do this, orchestrated all these efforts at different level and at different policies. And where does the private sector fits in this framework, if you will? Professor Siripan talked about the role of the private sector. They can be the payers, and sometimes they can be the suppliers, but most of the times we understand them as the providers of services, whether they are for-profit providers or not for-profit providers. And in the mixed health system, we will see the combination of public financing, private financing, public delivery, and private delivery in play. And we understand that the role of the private sector is quite significant because they have a potential influence on, making sure that there is a quality services available, making sure that there is access to care, making sure that the health outcomes and the national priorities are met. So these are the very strategic role of private sector, and this is why we want to engage them. But engaging the private sector needs some kind of leadership and some kind of governance capacity from the government. And the good governance will enable the three actors in the system, which is the policymakers and the providers and the people, to have a very accountable and transparent and patient-centered care and relationship, if you will. And one of the most important aspects of good governance could be seen through the health financing mechanisms that is available. And then Professor Laksono talks about what are the functions of the financing. And financing is not only about raising sufficient resources, but it's also about making it sure that it's equitable and also efficiently managed. And the kind of purchasing and payment mechanism that you choose in your country will very much depend on what kind of policy instruments that you use and what kind of behavior that you want to have in your system. So whether it's going to be a passive or a strategic or whether you want to use budgetary or capitation at the meso level, or whether you want to use agreement for the health workers using remuneration or fee for services, these choices will affect or will influence the way that the providers are in the system. And one other way of making sure that there is a good governance regulation. I will talk about regulations that we are familiar with. To understand what is actually what we do it and how we do it. And here we will introduce the kind of pyramid from the bottom and the very, very low. The pyramid, which we go to a more structured implementation of the how the providers and the private sector and they will respond to those kinds of regulations with a kind of liaison. So that was summary of day one, and I hope I didn't miss anything. But if anyone here remembers something, I'm happy to hear from you. Is there anyone? No? Okay, wonderful. So day two and day three. And I will move on. Question, which would be whether there is a sector is there. So in the framework, you can see that the big chunky block here on the second row, second column, this is all talking about the assessment, the private health sector assessment. This is just a lot of things. We want to have a more targeted information about some part. It depends on what kind of health system goals that you have in mind and what kind of so If you want to identify, simply identify the private sector and role, then you can do that. And then you can understand, is there any opportunity for private sector engagement? Or do you want to understand the action between the public? Action. Or do you want to understand identify, is there any policy instrument that you can use to improve the enabling environment for private sector to produce better quality? Or do you want to engage the stakeholders in a policy dialogue? If you have a particular innovation, a particular reform that you want to integrate and that would involve the private sector, then you probably want to engage them. Or you want to develop a comprehensive and strategic and effective sector engagement strategy. And then, you do in order to have a clear understanding of the sector. Oh, I'm sorry. So the question about really, how much do you understand and how much do you understand about the linkage between the public and do you understand about your private sector really talks about how much do you understand about who delivers the services in your country, in your system? Who are the private sector and how are they delivering the services? In your system, how are they doing that? And if there's any intermediary that connects in what role should we play? This is the components, if you will, of the private health sector assessment. These are the things that you want to understand. What is it? Would engage then we do more in your system. Do you want to evaluate that will be a more predictive? These are the things you need to understand about the private sectors. Those are the things that depends on how much and one of the major providers in the system. We need to understand what are the providers of private health sector that system? There can be a whole range of providers type. Can be traditional healers. They can be a super staff. We want to understand who they are, right? So you also want to understand the method. Sometimes we have a lot of information, but we have very little information about it. We have the portion of the sector in our total expenditure. These are the things that everyone probably will need to understand objective behavior of the sector. You also sometimes need to understand the kind of result, what kind of what kind of number of applicants for the project. This is a deep understanding about the magnitude of the project. So it's not just about the numbers of the providers, but depends on the objective of your private sector. It can be a mapping of the private sector. It can be an analysis of the aspect. It can be an analysis of the capital that are available. It can be an analysis of the quality, the equity, and the efficiency of the private sector. It can be a multiple analysis of the private sector. Again, how much do you need to know? Really depends on what objectives do you have in mind. So thing that you need to understand is define. You need to understand who pays what. So how is it paid for? Because these are the things that to some extent and we need to also understand, is there any kind of access that they have to different kind of financing? Can they access the public financing, or do they rely mostly on the public financing? What kind of financing mechanism is available? These are also the things that you need to understand. And again, you also need to understand the magnitude of this financing part to your private sector. At some point, do they have a specific unit dealing with the private sector? Do they have experience in using private sector? How? You have a relationship. If you do have a mutual trust between the public and the private sector. And these possibilities Again, is there any access to public financing, or is there any subsidy or tax subsidy available to the private sector? What are the regulations that are available to the private sector or that are regulating the private sector? Is it ensuring quality? Is it ensuring access? Is it ensuring equity? And what about the other resources that also happening at the private sector, because they sometimes also be suppliers in the system, as Professor Siripan also mentioned yesterday. They can supply drugs, they can supply medical equipment, they are the producer of these things, but they also produce human resource for health. Sometimes we forget that they also have, private education institutions producing health for health human resources. So these are the things that you can try to look at when you trying to understand the linkage between the public and the private sector. So when you do have those in your at the back of your mind, if you will, then you need to develop the assessment strategy. So you need to ask what are the qualitative data that you would need to understand whether the private sector plays an important role in your system or not. Because in some countries, even if it's a mixed health system, you understand that there are some countries with a major private health sector player where the public sector is a bit more smaller, or the other way around. So you need to understand how do you want to gather this kind of information about the landscape of the private sector. And also, is there any quantitative data that you would need to be able to formulate a strategy or to be able to mobilize the private sector towards meeting your health system goals? And not only quantitative data, but you also need qualitative data if you want to understand about motivation that the private sector has, the motivation that the public sector has. These needs probably be explored more in a qualitative ways. And then, of course, you need to think about how would you effectively collect this data. Is there any data source that you can rely on? Is this publicly available? Or do you need to do a primary study to collect all this information? So with this in mind, you will have to develop an assessment strategy, looking at different kinds of aspects of the private sectors that you want to look into, and understanding what kind of data that are available and what kind of data that you need to gather yourself. And you can start to map this in a very simple way. What are the policy areas that you want to understand? You want to understand and describe the private sector. Then you map out what are the data that are available in your country to understand that, whether you want to do a literature review, whether you want to do data collection from all the available secondary data that are available in your country, national surveys, whatever it is, or whether you want to also add on more primary studies to that. Also about the linkage. When you want to try to understand the linkage between the public and the private sector, you can always do a document or regulation review, but then you also want to understand, again, their perspective on the linkage between the public and the private sector as well. So these are the kind of simple way to map out your assessment strategy. But I think I would want to stress that it is important, if possible,
to create a mechanism that encourages participatory engagement with the private sector, meaning that you might want to include them in your assessment. You might want to have them as well as the informants to you, because you want to understand the perspective, of course. So this is something that you would need to do. You need to engage them in interviews, sometimes in focus group discussions, or you want to have a mechanism that's collect this kind of information in a more regular basis. So it's not just a one-off thing that you do and then you leave. You want, again, to start building a relationship with them. So why not start with the assessment part? So those are the way that the private health sector is done. But I think I would need you to really see how's the private health sector look like. What are the results of the private health sector assessment, for you to really get a sense of this is how to do it, or this is the things that I need to also have in my country at some point if you want to engage the private sector. So at your table, I think you already have a case, and I'm going to ask you to read the case for about 10 minutes and have a discussion about that particular case. Try to understand what is it that the government is trying to do with that assessment. And do you think you have enough information of the private health sector in that particular case, and whether you need to have more information and you think there is still some information that is still lacking, and how would you do it, or how would you do it differently if this is happening in your country, or if this is something that your country wanted to do. So this is a case of the Philippines. And I will give you about 10 minutes to read them through, and then come back to me with your result of the discussion. Is there any questions before we go into the group discussion? No? Quite clear? Wonderful. So thank you. Yes, hello.
Sorry, yes. Just make it clear. This private sector in this discussion, if we have, okay, thank you. The private sector in this discussion is about something like between the hospitals or clinic or private sectors lah. But if you mean that it is about pharmacies or it's insurance, it is also called as the private that we are discussing later. Is it, or just clinics or hospitals or primary care?
Well, you can see from the case later on that the assessment comprise of different aspects of the private sector. And I'm sorry. Yeah, okay. Sorry. But yes, to answer your question, when we talk about private sector, when we talk about the need to do private sector assessment, we want to understand what are the roles that the private sector is playing. They can be providers, so they can be hospitals, clinics, or private practice, whatever. Or let me go up here. So they can be a range of providers,
Yeah.
right? But they can also be the financiers of the health system. So City Pen yesterday talked about, insurance, private insurance, right? How is it that they are play a role in your system, being a payer in the system, ensuring, or in I think, what was it, in some countries' cases, they are able to top up the kind of social health insurance that you already have in your country, in order for people to access more care if they choose to do so, right? So those are also private sectors in the insurance. But we also talk about
private sector as the suppliers to the system.
Because they produce things like they
Like
manufacture
pharmacies.
pharmacies, they can be producers of drugs, the pharma companies, but also medical equipments, right? And they also produce human resource. Do not forget about that, right?
Yeah. human
So
resources.
yeah, so those are also private
Also
sectors.
will be discussed here.
Yeah.
It's also yesterday's discussion and
Mhm.
also next. We have two discussion more, right?
Mhm.
So it's also the private sectors means not only the providers, but also like suppliers or even the financial.
For the case that you are working on the afternoon,
Yes.
yes.
Oh.
So when you identify, yesterday you identify, I'm sorry, I'm talking about the group discussion. When you identify what kind of challenges that the private sector has in terms of integration of services, then you talk about those things as well, not just the providers,
Providers.
just not just the
Yeah,
providers.
because
Also
yesterday we discussed actually
only about the
only about the
providers. That's all right.
providers, yes.
You can add more discussion later on today. And also again, not only the providers. And why are we not only discussing about providers? It's because when you discuss later on today about the strategies that you can use to engage the private sector, the strategies are not always aiming at the providers. Strategies can aim at, different actors.
parts, yes.
Yes.
Then like collaborators, maybe we can learn from COVID-19. We have
Sure.
many collaborators from private sector.
Sure.
Yeah.
Yes.
Oh, okay. Noted. Thank you.
Thank you. But for this particular case, this is not related to the group discussion later on that you will have in the afternoon. This is just a case for the private health sector assessment. So I just want to make that kind of distinction. So you just need to understand what does a private health sector assessment look like at the end of the day when you do that, right? And what kind of information that are reflected in this result that you feel, okay, this is sufficient information, or no, I need more information about the private sector. And how would you do that if it's, you're trying to do that in your country? All right, so is that clear? Okay, so thank you. And please have a good read of the case and then have a discussion among your table. Thank you.
Ya, Bapak Ibu, saat ini kita sedang mendapatkan penugasan, namun memang di sini kita diminta untuk mengidentifikasi dari materi yang sudah diberikan, tapi sayangnya kami belum bisa dapat men-share juga materi yang online-nya gitu untuk peserta online gitu ya. Jadi emang ada bahan bacaan sendiri dan kami diminta untuk mengidentifikasi terkait dengan isu yang ada di Filipina gitu. Kami coba untuk usahakan agar file PDF-nya dapat dikirimkan juga. Mungkin kalau Bapak Ibu ada yang ingin ditanyakan bisa disampaikan begitu. Terima kasih. Bapak Ibu peserta online, saya sudah mengirimkan bahan untuk diskusinya di WhatsApp grup kita. Jadi mohon Bapak Ibu untuk mengecek WhatsApp grupnya sebentar. Nah, dari bahan diskusi yang sudah saya kirimkan ini, saya persilahkan Bapak Ibu secara mungkin Mbak Nila bisa bantu untuk pembagian kelompoknya juga kalau boleh, atau secara mandiri juga nggak apa-apa. Sementara ini silahkan mengikuti petunjuk yang ada di PowerPoint. Nah, yang pertama Bapak Ibu perlu mengidentifikasi di dalam artikel yang telah saya share di WhatsApp group itu mengidentifikasi apa yang apa tujuan pemerintah yang sedang coba untuk diselesaikan, apa permasalahan yang dicoba yang ingin diselesaikan oleh pemerintah. Lalu uh, uh, kita perlu juga mencari informasi terkait bagaimana pelibatan sektor swasta dan apa yang apa perbedaannya begitu ya. Mungkin silahkan dicek dulu di WhatsApp group, nanti materinya hasil kerjanya nanti bisa di-share juga ke WhatsApp group kita begitu, atau bisa share melalui kolom chat ya Bapak Ibu. Terima kasih.
Right, so have you finished your readings? No, not yet. It's okay. Oh, we can start the discussion, if you will. So first thing first, which country is this? Philippines, of course, it's the easiest one. So no rewards for that. And so when you're reading the case, can you identify what is the goals, the health system goals that the Philippine government is trying to do when they're doing this private sector assessment? What is it that they wanted to do? What is it about the health system goals that are lacking, if you will? Sorry?
Access, planning.
Family planning services. And in particular, is there any specific groups of target that they're thinking? Adolescents, yes. Yeah. So they want to improve access, right? They want to improve access. So when you sorry. So when you do a private health sector assessment, again, think about what kind of health system goals that you are trying to address. So in this case, we are talking about improving access to family planning, especially for adolescents. And what informations do you currently have with the health sector assessment result that you were reading? Midwives, yes.
The most providers.
Most providers are midwives.
In private sectors.
In the private sectors, the most providers are midwives. Is there anyone else picking up any other informations? Sorry?
The Catholic Church opposed the idea of family planning.
The Catholic Church opposed the idea of family planning, especially amongst the adolescents, yes? Okay, what else? What other information that you picked up? Yes?
Information on the accreditation for the different types of health professionals and how the DOH and PhilHealth play a role in that.
Thank you. Is there anything else? Yes?
There are a lot of international donors, and they also play an important role.
Yeah.
Yeah, they have really good collaboration between private and public, but the distribution of the health professional, doctors is 50-50, but for midwives and nurses, majority in private than the public.
Okay, thank you. What about the policy around the private sectors? What are the policy instruments that were used to the private sectors? What are the governance mechanisms that are in place? Can you pick up on that? Yes?
Midwife service is covered by the PhilHealth. It's covered the service. That's why the service is moving.
Yeah. So there is information about how PhilHealth is used or utilized for ensuring access to family planning because it is covered, right? What else? Degradation mentioned before. Accreditation was also used to expand the kind of services available in a quality manner. What are the challenging components? What are things that inhibits the engagement of the private sector for family planning? Yeah.
It's written here that the private sector's engagement is only applicable to national level services. So for smaller clinics, it's hard to identify them and engage with the private.
Thank you. So the big players are usually engaged, but the smaller players are somewhat neglected, right? Okay. Great. Wonderful. Any other things that you picked up from the case? What kind of other informations that you got?
The midwife is the most provider, but they lack of competency for intrauterine device or implant.
All right, thank you. So I'm sure there are a lot of informations there that you can get from the case. I was just wondering if anyone could also guess what kind of data collection techniques that they do to gather all this information in this case. What comes to mind? What kind of data sources that they use? Yes.
I mean, it says that they did focus group discussions, so that, and I guess some sort of policy analysis of the regulatory and the broader policy landscape of reproductive health.
Mm-hmm. Yeah, so they do peer review and also gray literature document sourcing, right? And also focus group discussion with the stakeholders, with all the players in the family planning services. So is there anything you would like to change if you want to do this kind of private health sector assessment? Is there anything that you would do differently? Is there any information that you think is still missing that you want to understand more? So that, you know, helping you to identify what kind of strategy would be more effective. Sorry.
The financing part of the system of the service.
The
financing.
Okay. Yeah. One thing. What else that you, and how would you gather that information?
Maybe from the Ministry of the Finance. I'm not sure.
Yeah. Okay. Thank you. So although we understand that the most of the services are provided there, but we don't really understand the magnitude of the financing part, right? Yeah. So wonderful. So that's how a private health sector assessment result looks like. And I hope now you get a sense of what is a private health sector assessment. And this one here, this particular case, do you think this is a comprehensive private health sector assessment, or is it a very specific targeted private sector assessment?
Maybe a little bit limited. So if they can do something like survey questionnaires that they can cover all the private doctors, maybe that
nanti di
more
prodi tapi ya.
Responses or results.
Yeah.
Jadi kamu minta ke prodi.
And one big piece is
absen,
also probably missing, if you can guess.
Ya, bisa selesai. Udah
The
sehat.
customer perspective, right?
Users.
Yes, the users, exactly. Yes, the users' perspective are still missing. So you don't really get information about what is the actual preference of the users in accessing family planning, right? Especially among the adolescents and the young women. So again, thank you very much for your all participation and contribution to this session. And I would like to hand over the next sessions to Professor Hung. Thank you, Professor.
Hi, good morning, everyone. I think there's a change of schedule because the original speaker is still on the way back to the hotel. So will swap. I'll talk about the situation in Hong Kong first. Now, I'm City Hong. I have done a little bit of accreditation in different institutions. I've been doing accreditations for the training for ANHSS departments in my previous life as an anesthetist, and then I've done some accreditation work for medical schools because they have to comply with the sorry, forgot remote again. Okay. Okay. Anyway, I've also done some work for the medical schools because they have to comply with that before the medical council will kind of agree that they should continue to train doctors, and also for hospitals and different types of organizations. So this will be based on the our Hong Kong experience there, and that talked about the external quality assurance and accreditation in the Hong Kong context. Now, I would like to start with a story first. Okay, I drink coffee every day, not as heavy as Professor Yeo. Okay, Professor Yeo drinks about 6, 7, 8 cups per day. I drink only about 1 cup per day. I'm very disciplined, okay? And I've got a coffee machine at home. Press the button, and the beans will become coffee at the end in a minute, right? So that depends on how I maintain the machine in a good way. So I order some consumables from a online local Hong Kong vendor, and last week I ordered some filter cartridges for the water filter, right? So in 2 days' time, it arrived. Nice package, good. I just open it and then change my water cartridge. The day afterwards, I received another package, exactly the same. I thought, what happened? So I opened it again and discovered it was the same items that I've ordered. The invoice number was the same, the order number was the same, etc., etc. So, Shaman, what will you do?
Contact the vendor to see if there's any issues or problems over there.
Well, there's several options. Of course, you can just silently throw that away, or you can contact them and call them, whatever. But for me, this is not the first time they did it. The first time was 2 or 3 years ago. They sent me something which is a kind of replacement part for the coffee machine. Right? So previously I ordered some replacement, but and then they sent me another big package of replacement parts. Right? So how do you think of this coffee company?
So they lack of a system to monitor. Yeah.
So obviously, if I were going to invest my money into this company, I would immediately sell all my shares, right? So this is not a good company. Now imagine if it is a healthcare institution. If they give you something in addition to what you require, and that would be not good, right? So that all comes to the purpose of the external quality assurance and the accreditation. So I think the main questions I would address is whether external accreditation will bring about positive results and the most effective way to achieve the external quality assurance. I will talk through case studies in Hong Kong, the Hong Kong hospitals, both the public and private hospitals, and then use other examples and then see what are the challenges that we have encountered and evidence that accreditation improve outcome, and eventually how we should use accreditation to improve outcome. Just a brief recap on Hong Kong system. I think by now you would have known more about the Hong Kong system. This is a dual track system, what we call, and the public-private share in terms of the finances would be about 60-40, 60 public and about 40 from the private. But of course, if we talk about the inpatient load versus the private versus the public, in terms of the inpatient workload, the private only takes about 10% and the public is 90%. So predominantly is a public service. And I think yesterday, Professor Yeo talked about the corporatization of the medical and health services back in 1990. And we now ended up with a big hospital authority, and there will be about 43 public hospitals and about 14 private hospitals, right? And all the private hospitals, you either pay through insurance or you pay out of pocket. I think about 40% of people in Hong Kong have some kind of health insurance, but the coverage varies, and most of that will only cover inpatient charges. So outpatient charges, most of them will not be covered. I think earlier this morning, there's also the continuum of regulation. I won't go through that again. And then just talk through the hospital authority story first, and then the private hospital story first, because I was actually involved in part of the work. So after the hospital authority was formed, and you know, we have got a hospital authority board. The board looks after all the entire hospital authority, and there would be a hospital governing committee for each individual public hospital. So the part of the roles will be to ensure that there will be quality being provided in all the services being delivered. And there would have been different attempts to try to improve the quality. So initially they organized a lot of the forums, a lot of the introductory workshops to teach the frontline staff how to improve quality, right? So and then et cetera, and then eventually they thought that that is not structured enough, right? Just like the coffee company, right? I think there would be something wrong with how they manage all the invoices, and then it became clear that they should have a system there. And then part of the HA annual plan was dedicated to be the quality section. So we call that HA annual plan section 3. Now, as it evolved, it became clear that of the 50,000 staff of hospital authority at that time, I think only a very minute portion knew about the existence of something called HA Annual Plan Section 3. So if you were to really improve the quality on a corporate-wide scale, then something needs to be done in order to promote the awareness of the entire subject on the issue of quality. So there were the initial discussion that should we invite some external persons to come. Initially, that was not about an external organization. Initially, there was the talk about, oh, you're A hospital, you're from B hospital, why don't we invite A hospital to look at B hospital, and B hospital to look at A hospital? So fine, okay. So we tried that, but that didn't work too well. And then eventually, of course, JCI is a organization that knows how to extend the businesses. And JCI came, and we tried JCI, and at that time I was working in one of the hospitals, and we lined up all the documents of the hospital, and the documents of the hospital went from here to this end. So imagine if you're the frontline worker, how much time do you need to read all those documents from this end to this end? At least 1 year, if not longer, right? So again, the uptake of JCI was quite limited, but they did teach us something about the tracer methodology, which I think was very useful. And at the same time, in the private hospitals, the private hospitals in Hong Kong, they are regulated by the Department of Health. There's the hospitals and clinic ordinance that looks after all the private hospitals and the private clinics. Unfortunately, in 1998, there were 3 patients who died during the process of renal dialysis, and it later became clear that after they cleans the reverse osmosis machines with formaldehyde, the washing out process was not done properly, so that killed the 3 patients. Now, again, that sounded an alarm that something needs to be done to all the hospital systems to improve the quality and safety of all those systems. So eventually, for the private hospitals, and of course with the assistance of the government, Sir Harry Fang invited the Trent Association of UK to come and accredit the private hospitals that went for the 10 years. And then it was at that time that the Department of Health, they came up with the code of practice for the private hospitals. And the code of practice went through several revisions. The first edition that came about in the year 2003, the year of the SARS. And then the Department of Health conducted quite regular, both announced and announced visits to the private hospitals to see how they were doing. And it was then eventually that hospital authority, together with the government, together with the private hospitals, thought that there should be a kind of single system that looks after all the public and the private hospitals. And that was eventually where we came up with the accreditation with the Australian Council of Healthcare Standards in the year 2009, whereby there were 5 pilot public hospitals engaging in the accreditation, and there was another, I think there were another 3 private hospitals engaging in the exercise. So later, this was extended to all the acute public hospitals and some extended care hospitals, and all the private hospitals were involved. The story went that Hospital Authority in the year 2017, the year after my retirement, suspended and eventually terminated the contract with the Australian Council of Healthcare Standards. But the exercise with the private hospitals went on. So back to the ACHS, it was just a 4-year cycle, and there was a clear standard and criteria. This was about the public hospital. So I think we could learn something from all those stories there. That in Hong Kong, there's a legislative council where in the legislative council, there's a health panel that discuss everything related to health issues. So accreditation as a big exercise involving the hospitals and involving the services that the patients would receive, obviously would receive attention at the Legislative Council. So at every phase of the extension of the accreditation project that went through the legislative panel, and a lot of information were dug up from the papers of the Legislative Council. I have no insider information, I can guarantee, okay? And there were, after the 5 other hospitals, there was actually a positive impact from the assessment or from the evaluation. That was the study done by Professor Eliza Wong from Chinese University. And the chief managers all consider that to be very useful, acceptable, feasible, etc. But that require experience of the surveyors, okay? And we'll see later how surveyors and organizations would make a difference there. And they also need to make sure that the extra resources required. But again, sorry, I put too many but there. The frontline staff will feel that it is very stressful. Jackie, do you feel the stress?
No, I think also a bit too young to have to be in that managerial role to participate in the accreditation at that time. I was a training.
Thank you. Anyway, that was from the staff that they feel quite stressful because of the workload, and they perceive this as an examination and not as a continuous improvement process. Although you could see here that additional funding from the government to hospital authority and then to the individual hospitals, as well as to engage the ANHSS, has been done, but that money is probably may not be enough, right? And eventually spend more, of course. And then HA subsequently kind of revised the timetable to say that, oh, we shouldn't be that aggressive. We should take time, okay? Because if you want to improve the hospitals, services, many of that would involve facilities. You can't change facilities overnight. So that solved the first crisis on extension from the 5 pilot to the another second group of acute hospitals, and the phase 2 launch in October 2011. And then that eventually went through phase 3, and phase 3 was to involve 10 more hospitals. And then in 2016, there was the saying that now the convalescent and the rehabilitation hospitals should be involved, and that was in the I think in the early 2017 that there were a lot of staff grumbling about the work of the accreditation, and that put a stop in the accreditation exercise. So that was about the public part. Now, I extracted this from Dr. K.O. Zhong, who is now currently those of you who will be joining the hospital visit on Friday will see Dr. Zhong. He's now the current cluster chief executive, and this in the Prince of Wales Hospital. So he was summarizing the sentiment from the staff, right? So there were some positive ones, team building, additional resources were given. For example, there are two things that I'm very that have quite a deep impression on me, because one was on the credentialing. So I was the head of the first batch in one of the hospitals in the first 5 pilot, right? So and in the ACHS standard, there's a standard on credentialing, and you know that Hong Kong and Australia are running different systems. Australia, Hong Kong system is they're all public, and we know who are they coming from, okay? And we know each other quite well. So there's not this sense of credentialing in Hong Kong, right? So and then it, but anyway, we make some changes, and we made up the credentialing policy over a short period, and then that worked, and that was one of the, and now the credentialing and the score practice is going strong in both public and private hospitals. I think that was a good kind of achievement from the accreditation. And the other is about the sterile facilities in the hospitals. So Australians, they insist that there should be clear segregation of dirty from clean corridors. There should be whatever, and that caused HA to upgrade a lot of facilities in the public hospitals. I think that was the way we went by additional resources, and there were of course regular reviews just to make sure that things are going well. I mentioned regular review because we did another kind of exercise on one of the district health centers. And when we visited the district health centers, everything was well, okay, of course. But then the year afterwards, we heard that it wasn't that good actually. In fact, it was the lack of regular external review that makes the improvement not sustainable. I think the sustainability of the improvement is important here. And all the negative things, I think we have heard about: extra workload, some recommendations not applicable, too many documentations, or the variations between individual kind of surveyors or the what they call assessors nowadays. However, for the private hospitals, this is entirely different. This is entirely different. Now, all of the private hospitals joined the ACHS since the successful pilot program. Actually, they did very well. One of the private hospitals, when we were still in the Equip 6 period, scored one outstanding achievement, which is nearly never heard of in the Equip 6 kind of standards. The other important thing about the private is that because of another incident, I think yesterday, Professor, you also talked about government actually revamped the entire ordinance about private hospital regulation. And during the consultation period for the amendment of regulation, that it went that each private hospital should be accredited by some external agent. Okay, so it didn't end up being written in the law, but this was common belief that every single private hospital must be accredited by one of the accreditation agencies. So that was the understanding. And of course, the most recent development is that our new health secretary has said that accreditation should be done in the public hospitals as well, in addition to the private. And they some of the hospitals will be adopting the so-called International Hospital Quality Accreditation Standards from Shatin Hospital. So they have kind of modified the accreditation standards in China and internationalize that set of standards. And again, the Prince of Wales will be one of the first other hospitals, together with the PMLU, the Northern Eastern Hospital, to go through that new international hospital quality accreditation standard from Shenzhen, from China. Right? Code of practice is a good way to regulate and to accredit as well, because we understand that if it is accreditation by legislation, then every time you have to change the legislation to make some new changes. And changing legislation would take a long time, would need a lot of discussion. But this the little white, well, not little white, but this is important code of practice. You can change it quite easily, and this has gone through several additions. The name has changed now because the maternity hospitals, our maternity units are under separate ordinance. So this ordinance just cover the private hospitals, and the compliance with the code is a condition for renewal and for issuance of license. So if there's a single item that you do not comply with the code, then off you go. Bye-bye, right? So, and this make it quite mandatory. And they have actually, I think based on this, Department of Health conducted a lot of unannounced visits to the private hospitals. And they actually, now, I think that in subsequently we say that if we use legislation, then certainly it might be difficult to change the standards because legislation usually would prescribe the lowest minimum standard that everyone could achieve, right? But in fact, through the use of code of practice, they've actually tried to improve the standard. So in one of the examples, a private hospital was doing a fire drill involving patient movement every 2 years, right? So when DH went and visited the institution, they actually suggested that the frequency should be increased, right? So eventually they changed the frequency from every 2 years to every 18 months. So using this code of practice or combining this accreditation with the legislative approach could also be useful and help to achieve some quality improvement changes. These are just the different components, and that this is where in the first time they say that in the hospital there should be a doctor the 24-hour round, right? So that would be the requirement, and that defines what is a hospitals and what is intensive care unit, what is a AE department, etc. Right? So that is all with the hospital accreditation. Now we have actually extended the concept to accredit healthcare organizations. Now in Hong Kong, doctors and nurses and physiotherapists, occupational therapists are regulated by law. But there's some healthcare practitioners which are not regulated, but the risk is quite high. So we actually went through the what they call the accredited registration scheme, using the kind of voluntary for them to register as the in the register. And again, we took reference from the accreditation framework and applied that to accredit those organizations so that they could serve as a registered function. So this would be for the healthcare workers or the organizations holding a register for healthcare workers. This is for this district health center. I think the accreditation is basically, first of all, there should be a standard, and then you send a team of assessors to see whether they have complied with the standards, and then how they could, if they were deviating from standard, how they could go back to meet the standards, and then there should be a cycle of improvement there. So those are the important items. I talk about accreditation and regulation. So basically accreditation is voluntary, but because of the voluntary nature, then that depends on the staff to do improvement works by themselves, right? So once you engage the staff, they will be able to, they will be motivated to do improvement by themselves, whereas compared to regulations, this will be mostly relying on minimum acceptable safety level. I think time is running short, so this is about accreditation. History goes back to about a century ago and has been widely adopted for different systems in the US. For hospitals to receive Medicare and Medicaid patients, you need to be accredited by one of the agencies. Again, so this is linking accreditation with the financial incentive. I think this is about the new ACHS equipped standards. I just want to say that now with the new ACHS equipped standards, you can go through the conventional advanced notice cycles where you know that, oh, I can set the time for the surveyors to come so that I could clean up my house, I could revise all my documents for them to arrive and say, well done. Right? This is one way. But I think we all know that if we do it this way, then they'll create a lot of work, and what you see actually may not be the true picture when you have gone, right? So ACHS now has come up with what they call the short notice cycle, which has been adopted by JCI long time ago, and adopted by Department of Health long time ago by the so-called the unannounced visits. So they will give you 5 days advance notice and then come and assess you. So you need to make sure that your system is good enough to meet with all those short notice cycles, right? So I think there are some questions there. That first of all, why is it so accepted in a private but not in a public hospital? Why is it so difficult to make it sustainable? And about the staff, right? Adequacy of staff and accreditation, and whether it only improve documentation but not patient care, and whether it's about the performance of the surveyors. I think there were some, in the literature, there were some consistent findings that promote change, professional development, but if we want to show improvement, this is difficult because this is such a complex kind of intervention. And if we're just using some simple measures to reflect the improvement, that is certainly difficult. So actually, and this is more a recent paper that showed that the consistent effect will be on safety culture, the process-related items, but the unrelated items will be on employee satisfaction or the patient satisfaction experience, etc. I think the questions that we should ask is how to incentivize the accreditation to institutionalize the improvements, and how complying with the standards would, how is that associated with the many benefits to improve performance. If we look at some inpatient mortality, both the studies from Korea and from Thailand, I think we've got some Thailand colleagues in the audience, have shown that for AMI and for stroke and for sepsis, those process-related items, there has been some improvements there, that is for certain. And studies in US also shows that in US there are 4 accreditation agencies, and there were less good results when certain accredited agency is doing accreditation. So it just shows the variation in the agency as well as the surveyor. So we, in order for us to make it work, we have to understand that issue as well. User experience is just a study from Hong Kong, which shows that the users were quite appreciative of the changes there. I think this is the important message there. It just shows that if you want to see evidence of improvement before you formally adopt, then you will never adopt accreditation, because this is such a complex intervention. So instead of asking to seeing the evidence, we should ask what type of, or what aspects of accreditation might work or will work in your context or in my context, and how can accreditation be improved in your context to enhance quality of care, instead of does accreditation work? Too general a question, we are asking the wrong question, might be, and too general a question may not be able to generate some useful answers there. The other part is certainly, this is from the WHO perspective, you would have appreciated that accreditation is actually quite expensive. We've been spending millions of dollars on accreditation. Now, I shouldn't say that money shouldn't be spent, but it is expensive. And when money is a concern, then we still have to think about what is the most effective way to spend that money, because at the end of the day, this is a tool to improve quality, to ensure that quality is being delivered in a sustainable manner. So there were other concerns there. So there might be simpler interventions that might work in low, middle income countries then. And eventually, it should not be, or I should put this way, accreditation should be put in the whole context of the health system, right? So it should not be an independent subject. So it should be linked to the entire quality improvement objective of the whole health system. And at the end of the day, this is addressing about the staff concerns, about the extra work, about the stress, etc. If we overwork the staff, they would never be able to give you good quality, never be able to give you good results. And engagement of the staff is the most important aspect from all the international literature. They are the central driver of quality, and they are the central driver of improvement. So last two slides, these were the 10 points of WHO. It should align with all the UHC commitments, cost, opportunity cost, etc., and ensure continuous process to improve quality. And I think people-centered primary healthcare is critical. That should be the focus of accreditation, and it should be supportive, not punitive, right? So, and we should also balance local adaptation and standardization. Now, of course, if we work high up in the hierarchy, we want every organization to look the same, okay? But in actual fact, that may not be necessary, and that may not be useful, and may not be conducive to improving quality. Every single hospital has got a different heritage, has got a different baggage, right? So it would be local adaptation might be more useful than standardization. So to conclude, we have to bear in mind that quality improvement is a systems approach, and that must be linked to some funding mechanisms. There are some positive changes, but we should be clear on what accreditation should do, and we should ask how would this help our organization, right? So, and then the last point is about the staff, okay? They are the central driver of changes. So we should engage them, protect them, and make accreditation useful to them. So that would be my sharing here. Any quick questions? Yeah.
Thank you for interesting information on the accreditation. My questions are, the first one is, when the health facilities do not meet with the minimum standard of accreditations, and it will affect the license to operate. So then another issues will come up, like sufficient access for the community. So like the ratio of bed to the populations. So how to overcome these issues? And the second one, how about in Hong Kong situations? Are the private sectors having like subsidies, or the government also subsidize the private sectors to meet at least the minimum standard of accreditation? Because since it costs a lot. Thank you.
Okay, now your first question is not meeting the minimum standard. I think that should be known before the accreditation. So some work should be done to improve that minimum standard. And many a time we would give time for them to make good for that. Let's say I give you 3 months, and now I'll come back and see you again, right? So, but if it is about the number of beds, etc., then that couldn't be sorted out in 3 months' time, right? So, and the government has to work together with, because if it is about the access, if it is about the health services, then we also need to balance the local adaptation versus standardization, and whether the standard has been set too high. But certainly you cannot change the law, unfortunately. The Hong Kong system, private hospital, private is private. They don't receive anything from the government. They have to make sure that they can make the ends meet. And of course, it will be coming from the charges they charge to the patients. Okay, any further questions? Yeah.
Thank you, Prof. See you again. Talking about hospital accreditation, I also have experience with accreditation in hospital, and I am one of the members lah in the hospital doing all the documents, so many documents to be submitted at a time. I'm asking you about how many institutions in Hong Kong doing this accreditation, and whether how can we qualify to do that accreditation. I mean the institution, because sometimes we found that the surveyor, we say that surveyors, the one who is doing the survey to do the accreditation in hospital, could be very subjective. And sometimes I found someone coming to hospital, one say that this must be like this, but then the other one come again and saying this different thing. But what happened in Hong Kong, is it happen too, or they have standard, and every institution doing the accreditation has its own standard, and who also doing the accreditation for the institution itself?
Okay, now in every accreditation team, there will be a lead surveyor, right? So in the ACHS system, and in my previous experience as well, at the end of the day, before they decided to make any recommendations, they will discuss within the team. The team would consist of local surveyors as well as international surveyors. So obviously international surveyors may not know the local situation too well. And then they would discuss with the local surveyors. And if there's still issues, they would take the issue back to the hospital management and see whether this is acceptable practice in the local context. So that just makes sure that to avoid the comment being too personal or too biased. I think this has evolved over the years to make sure that the comments given are fair to the organization. And of course, the surveyors need to be trained. If you are not doing well, the next time you might not be invited to be a surveyor. So there will be a training, and the lead surveyor will comment on every member at the end of the visit, and that will be filed to the agency. Right. So your second question is that the accreditation agency is an international body, ISQA, International Society of Quality, that accredit all those individual accreditation agencies.
How many agencies in Hong Kong? Sorry? How many agencies here? And I mean the institution for the accreditation, hospital accreditation.
We currently, some hospitals are being accredited by the Australian agency, the ACHS, Australian Council of Healthcare Standards. We have been talking about whether there should be a local agency, but that hasn't come yet. And now some hospitals are using the standards from China, from Shenzhen. So, okay, so there's still no local agency.
There's no local agency. Oh, okay, I see.
Okay, I think that we have to come to a close to the session. If you still have questions, you can get me anytime during tea break.
Thank you, Prof.
Recording stopped.
Session will be on Zoom. So give me a moment to open the Zoom link first. Because Professor Adi has an urgent thing to do in Indonesia, so she'll fly back.
Let me check if, can you hear my voice? Hello?
Yes, Professor, I can hear you.
Okay, okay.
But
thanks.
hang on, I need to check people in the room because I'm outside the room. Hang on, Prof.
Yeah, Mbak Lika, Prof. Adi, we can hear your voice in the Zoom, but in the room, not yet.
Let me know if I can start, yeah.
Ya, Prof.
And while you are setting the audio in the room, I'll just go to the toilet for a minute, okay?
Ya.
Hi, Professor Adi, are you here? So sorry, there's some technical problem. Just wait for a moment. So maybe we take a few minutes.
Jadi kayak ada poin yang mikir ke agama tidak pernah ya. Pension for everyone.
How about we have some coffee, Pacific coffee there. You take some coffee to your seat and then we can start. Yeah. There's some coffee at the back. You can take some coffee first.
Manajemen itu nggak mau tahu orangnya aja kita ditunjuk jadi jabatan mereka nggak ikut berproses menjadi jadi ada kita teman-teman maksudnya kayak yang tahu ikut tahu hasilnya ikut tahu proses menyiapkan juga kan dari hulu ke hilir itu ada tapi kayak yang kok cuma ya udah gue gak mau tahu kerjain aja gimana ya Jakarta pusat atau sih anak daerah itu udah saya pun ada gak enak juga di situ
Can you let me know?
Oh ya, Prof Uut. Ya, non saya Prof tadi karena mereka sedang
dulu ya?
memperbaiki soundnya, iya, persilakan ambil kopi dulu, iya.
Oh,
Breaknya
oke.
cuma di depan ruangan sih, Prof. Harusnya lebih cepat.
Oke, nggak apa-apa.
Seperti
Jadi
sore
aku
kemarin, ya.
bisa anu dulu. Jadi mulai jam berapa?
Oh ya sebentar, tadi nggak dibilang juga
10
sebentar,
minutes.
Prof.
Nggak.
Mungkin jam 11 mungkin ya. Bentar.
Ya, 10 minutes ya.
Iya.
Oke. Ya.
So maybe we take a break now until 11. So you can go to the washroom, get some snack at the back and get some coffee or tea. Yeah.
Saya bengong lah. chị嚟俾佢添。
我 send 俾我嘅，我 send 俾你。
OK。你做咩唔打我嗰個啫 ？Joyce Chan 啫嘛。冇啊。
Should we back this afternoon? Oh, okay.
Saya pergi bukan ya.
Alah, ini
I sent it to.
I mean, afternoon. Because some of them are already given by other presenters, so it will be redundant.
Makanya kita masuk Yes. And then there will be this is called Shatin. Very famous in Shatin. Right now we can go to supermarket. Yes, sir. Yeah, we want to go to the supermarket. Yes, yes, supermarket. Inside the so place because Shatin don't have two place, two big floors. Yeah, no four, two main floors. Oh, yeah, yeah. Building. This building. This is the third building. Yeah. You when you go out, then you see where it is because it's very big and then supermarket is here. This one that is a local supermarket called. We also go there to buy. Inside there. Yeah. Oh, also circle. Supermarket too. Yeah. So this is supermarket. Local. This is a with more local. Because I usually go there to buy the food. So you can buy something like this. And for this one, you can go to Shatin at the close button.
Just to get ready, can I operate the slide by myself from here?
Yes, you can open your slide now. We can start now.
Okay. Let me, yeah.
Okay, Professor Adi, you can share your screen for the PowerPoint.
Yeah, can you see the slides? Is it
yes.
On the slide share mode? Slideshow already over there?
Yes, it's okay now. You can start.
Okay. So, Professor Ikeyo, Prof. Laksono, colleagues and participants, good morning. And thank you, Professor Hung, particularly for very kind of you switching the session for this morning. I apologize that I'm not physically present there in Hong Kong, but I'm delivering this session online from Jakarta. So I hope this doesn't lessen the meaning of the session. And the first session by Professor Hung really makes me easier to deliver this, because I think many of the important experience, important concepts have already been delivered, and I believe also some of the references that we use are also the same references. So I'm not going through all the slides for now. I'm just choosing the one which is specific for Indonesia, and then a little bit of again highlighting what's the evidence so far that we have on the impact of accreditation, and ending with, okay, what's our challenges going ahead. So I will use this. I hope you can still remember a little bit of this pyramid regulations from yesterday. And I'm using this to explain a little bit of the accreditation system, particularly for hospital accreditation in Indonesia. So if I start from the top, the accreditation system in Indonesia is always has been mandatory from the beginning. So accreditation started in 1995 in Indonesia. And this, I think this was quite early actually, and it was about the same time when countries such as Japan, South Korea also embarked on accreditation. And since 1995, accreditation, as I mentioned, has been mandatory. So there's a law for that all hospitals have to be accredited. And then the accreditation was done by an agency called CARS, which is Hospital Accreditation Commission, we call it. So on the MITA regulation level, this means that this independent agency sets the standards and implements the regulation. So it's a single body that is mandated by the Ministry of Health to develop the standard and to implement the accreditation for hospitals. Now, since the start of universal health coverage in Indonesia with the social insurance system, I think it really is this social insurance system that force everyone, every hospitals, to be accredited, because accreditation is one of the requirements for hospitals to be eligible to be contracted by the BPJS, yeah, the insurance agency in Indonesia. So this means that the insurance agencies will only contract hospitals that are already accredited. And then the self-regulation part, I think, is the accreditation bodies that is assessing and accrediting facilities. And the patients, communities, I would say, not necessarily informed about the results of the accreditation. So in the bottom of this pyramid, the voluntarism, I think in the context of Indonesia, with the very large countries, and now you can imagine at the moment is more than 3,000 hospitals with various situations, from number of beds, specialties, leadership and management. up to also social conditions where the hospital is located. That situation, I think, makes the principle of voluntary very difficult. Well, maybe not very difficult, but at least it will take much longer for the country as a whole to improve hospitals. So that the voluntary part, I think it's more to do with the individual professions to strengthen accreditation with taking continuing education, to use the momentum for developing guidelines that is relevant for them, priority for them, and also for hospital, for example, to review whether and to assess whether they wanted to invest on new technology or just using the current technology. And then, yeah, this is milestones, I can say, for quality improvement in general in Indonesia. Yeah. If we look at this, I think this is as far as I can trace back. It could be previous milestones, that's possible, but as long as we can trace back, I think in the late 80s, this is when it started, and still very much on the quality assurance principles done by the hospital association. So it's more of a self-regulation mechanisms. And then in the mid-90s, I think there was a period where hospitals as well as primary healthcare, they are trying to implement this TQM, total quality management with quality circles in place. And I can remember at that time, there was also a national, what you call it, national champion for quality circles, where the Ministry of Health choose which hospital that performs very good for the quality circle. And then only in mid-1990s, 1995 exactly, this is when the hospital accreditation starts by the Hospital Accreditation Committee. And the way it starts is more on focusing on the services that they provide. So they have this 5 standard, 12 and 16 standard of accreditation. Then in the year of 2000s, I think there are also important quality improvement activities, such as ISO certification was also quite popular in that year. It goes beyond hospitals, I think, also for primary care, and then even district health offices. Some district health offices also trying to use this ISO certification to improve the services. In parallel with then, the country also started to focus patient safety in a more systematic way. So the patient safety movements, this is happening in 2005, and then followed by these declarations on patients for patient safety, 2007. That was happening in that year. And then in parallel, we have the competence national exam for physicians and for dentists. Also, Ministry of Health regulation for minimum service standard. And then later that year, 2009, I think this was when the Joint Commission International entered Indonesia. And some hospitals, particularly, I think, teaching hospitals, teaching and also national referral hospitals, and some private hospitals also took this accreditation scheme of GCI. Now, I think since then, the accreditation standard in Indonesia also from time to time are sort of moving towards the GCI standards. And along with that, I think in 2017, I think this is also the most important momentum where the Hospital Accreditation Committee was finally internationally certified by ISQA. During that time, I think it was the first time that Ministry of Health has this Quality and Healthcare Accreditation Directorate within the Ministry of Health. So if we ask for who is the focal point for quality of care in the Indonesian healthcare system, now it is clear that we have a focal point within the Ministry of Health. In line with the development of the hospital accreditation, I think it's also interesting to note that accreditation seems to be used as a quality of care mechanisms for other healthcare facilities. So as you could see here, 2012 is when the accreditation for lab was introduced for the first time. And then also primary care 2015, but this was, I think there was after COVID there was a discussion, and then now it's starting again, the accreditation for primary care up to post COVID, and we started implementing the accreditation again. What's an interesting development in Indonesia that happens quite recently was that for all these years, from 1995 up to, I think, 2020, so for how many years is that? The accreditation is done by mono agency, so by a single agency. That means if you are thinking of one agency, monopolistic, covering 2,000 something hospitals, and it's only quite recently, I think it's either 2023 or last year, that Indonesia is already made the decision to have multiple accreditation agencies. So currently we have 6 different accreditation agencies operating in Indonesia. And with these changes, just want to note that the role of the government also changed slightly. The role of the government as oversight, in this case also monitoring and also, well, selecting, first of all, the accreditation agencies, giving the permit, for agreeing for them to be one of the accreditation agency, and then also being able to monitor the performance of the accreditation agencies. So this, I think, it's an important change that happens in Indonesia. Hopefully for good, but I mean, because this is still quite recent, it's interesting to know what happens. Yeah, how do hospitals choose these accreditation agencies? Whether it's really based on standards offered, or whether they have other considerations to choose this agency. Now this slide, slide is from the Ministry of Health in Indonesia. So considering that the country is using the command and control, so by law accreditation is mandatory, and then this is also a requirement for the credential from the insurance from BPJS. let's see the recent situation in terms of how many hospitals are already accredited. So if you could see in this slide, up to year 2020, 2020 is when we experienced this COVID pandemic. The number of the hospitals not yet accredited, it's still quite a lot, yeah, 669. And only 62% of them are in the accreditation process. Well, if we count the hospitals that their accreditation status ends in 2023, which means that they need to be re-accredited. We have 2,400, more than 2,400 hospitals. But the good thing is perhaps because now we have the 6 agencies doing accreditation, so 92% is already in the accreditation process. So overall, I think 86% of hospitals are in the accreditation process. Not 100%, but I think this is the situation happens. Now, usually, even though it's already using the highest regulatory mechanisms, I think learning from the previous experiences, there will still be some adjustments, some sort of tolerance in a way that the hospitals can still be giving services for the social insurance, but at the same time, they are making sure that they are pursuing this accreditation. Yeah, so I think this is already towards the end. What I wanted to say is that, you know, train is a good public facilities. As Indonesian, now we are proud of our train transportation system. Very timely, very good, very clean, very professional. But even though this is a good public transport, when it's used for by too many people, then you end up with the system of not coping well with the demand. So I think considering the cost point of view, Professor Hung has also mentioned, and this could be the cost for the hospitals, for those organizations that is taking the accreditation process, or also for the cost of the government to implement this accreditation. I think I would say that the system in Indonesia relies so much on accreditation as the only mechanism. Is my voice all right? I heard.
Okay.
Yeah, I hope it's all right now. So so what I would like to say is that I think yeah, for a context like Indonesia, with a large country, large variations of healthcare facilities, with so many types of facilities, perhaps also needs to be considered how accreditation can help for quality improvement, but also at the same time not relying solely on the accreditation. And I think literatures provide that there are many activities, many mechanisms also that we can do for improving quality. Right. Now, towards the end, I think it's the same question that Professor Hung asked, because we know accreditation is the activities beyond the organization. So it's conducted by organization outside the hospital, outside the healthcare facilities. So in order for this accreditation to have a positive impact on the patients that we serve, then it has to go through some path, yeah, to make sure that accreditation being an intervention, as Professor Hung said, this is a complex interventions at the environmental level. How can it support the management and the leadership governance at the organizational level, and then further how it could improve the clinical care delivery system at the micro level, in which will ultimately impact the patient and the community. So I'm just going to show the summary of the impact of hospital accreditation. And I'm sure some of the references we use are the same with Professor Hung. But here is just to quickly summarize, the red in color is where the evidence is consistent. So this is coming from different systematic reviews. I'm not presenting the detail of the systematic reviews, but just quickly summarizing without looking further into the quality of the systematic review, but just providing the brief evidence. So the words in red is where the evidence is consistent from several systematic reviews. And here is interesting to see that for the hospital accreditation, again, this is reviewing hospital accreditation from different countries. And we need to bear in mind that when we say accreditation, it's not one system. It's everyone has different sort of characteristics of the accreditation system. So despite the differences in this summary of evidence, we could see that some evidence is good from the point of view that is consistent. For example, this clinical documentation, yeah, clinical documentation, on one hand, it's good because it improves the completeness. On the other hand, we could see that there's also a trade-off of staff being overwhelmed by different documentations. And then another thing on the micro system is that professional attitudes, perceptions, process of care has been quite positive in the evidence. It encouraged use of the clinical guidelines and for physicians to think about the pathways and different clinical algorithm, different ways of making sure that care is really according to the guideline. On the other hand, you could also see that when it comes to clinical outcomes and then consumer reviews, patient satisfaction, risk-adjusted mortality, the evidence has been inconsistent. So I'm not saying that this is poor evidence, but it's just being inconsistent. Also, to what extent that the accreditation can reduce medical errors is also still a challenge, inconsistent, and whether with the accreditation we could make the system more efficient and it even have improved financial performance. This is also something to be explored. Now, for primary care accreditation, which I didn't touch that, but just to say that I think primary care accreditation is implemented by less countries, yeah. And Indonesia is one of the countries, in addition to, I think, like Middle East and some other countries that use accreditation also for primary care or for puskesmas. Now, evidence is more limited, but even though from the existing systematic review, Some are the same with hospital accreditation in terms of documentation, quality standards, organization, better work conditions, better communications, linkages with primary care and stakeholders is also positive. And I think this could be a potential area also to explore when we talk about integrated, seamless system in this workshop. So, and other things remain inconsistent, whether accreditation could improve waiting time, for example, infection control practices, input standards, and these are still inconsistent. So I would like to end by saying that perhaps for us, of course, for researchers, maybe it's always a delicate question to ask to what extent accreditation could improve clinical outcomes, clinician leadership, satisfaction, patient safety, etc. I mean, these are valid questions to ask. But we can also put it in another way, if from the perspective of the managers, from the leadership and managers in the healthcare facilities. And that would be how can we make accreditation have a big impact on those areas? So in what ways, what are the approaches that so that we can more ensure that accreditation is not just done solely for meeting the administrative requirement, but really accreditation can make a change for the patients, for the communities. So thank you very much for your attention, and wish you a good time in the rest of the workshop. Thank you. I'll give it back to the organizer.
Thank you, Professor Adi. So maybe we can welcome one questions, if any, because we have 2 minutes. Any questions from the floor? Oh, there's no questions. So we'll end this session, Professor Adi. Thank you very much. Bye-bye.
Okay, bye.
Okay. Now we have to have and use them. Yeah, okay, sure. There are one from the information because of ambitious video by the team. It is still recording. What is the microphone? You can check this one. Okay. Maybe you use the mic. Sorry. You can use the presentation mode.
Okay, hello, good morning. Sorry to keep everyone waiting, but we had a few technical issues. So my name is Chantal Haberholz. I'm from the Faculty of Economics at Chulalongkorn University in Bangkok. And we changed the topic now entirely because we are going to talk about public-private partnerships, or more specifically, infrastructural mechanisms for integrated healthcare. And I'll focus on the international literature. I'll give you first a synthesis of what we know about PPPs and how they can be used to support integration of healthcare services. And then I'll hand over to my colleague, Professor Siri Pen, and she will focus on the experience of Thailand with PPPs. So we do a bit of the general background first, for those who are not familiar with the public-private partnerships, and then we move on to talk about the specific country experience. All right, so what are PPPs, public-private partnerships? So these are essentially very difficult to define. There are many different definitions that have been used. And in the broadest form, a PPP essentially is a long-term contract between public and a private partner, or partners plural, with the objective of partnering to deliver public health services. There are many different models, and I will explain the most common models in a second. So the objective of my part, which will take the first about 30 minutes, is to deliver or explain the key characteristics of public-private partnership models, and then to talk a bit about how useful are they to enhance the integration of healthcare services. Now, where are we in our conceptual framework? So we are here in this box, the policy instruments, and we're focusing on different types of integration, most importantly, organizational integration, and here horizontal and vertical integration, then functional integration, and of course, infrastructural integration. Yeah, so we are in this third box here. Now, let me just start with a few statistics. And here we encounter the first issue that surrounds PPPs, public-private partnerships, namely the lack of transparency. Even when it comes to the most basic data, it's difficult to get some estimates of how many PPPs are actually used in healthcare sectors. Now, why is that? That's because there are so many different definitions of PPPs. They're at different stages of development. Some are in the planning stage, others are already in progress. So there's very limited data on healthcare PPPs. In fact, most of the PPPs are in the transportation sector. So you know them from highways, you know them from other public infrastructure, exactly, projects. But they're also used in healthcare. Now, the data that I have here are actually not only healthcare PPP data, but more generally data on project finance in the healthcare sector. This is a limitation of the data here, but yet it allows us to come up with a few trends because most of these projects are PPP projects. So what we see here is essentially that the majority of these PPP projects are in Europe. So if you look at this part of the world, Asia Pacific, so then perhaps only about not even 10 to 15%. Yeah. So when we look at the PPP landscape, again, the bottom line is most are in non-health sectors and most are in developed countries. Maybe another technical glitch. Let me move over to this side. Okay, so I gave you a very broad definition of the PPPs earlier on, but let me now, excuse me, more formally introduce what a PPP is. And I draw here on a definition that I find is quite comprehensive. And that's the definition by Klein and Theismann that was proposed in 2000. So they define a public-private partnership as a more or less permanent cooperation between public and private partners through which the joint products or services are developed and in which the risks, costs, and profits are shared. You see, I'm taking time to breathe because it's a very long definition, but I like it because it captures nicely the key characteristics of a PPP. What are these? So the essential characteristics that make a PPP different from other policy tools like contracting are the following 4 points. So first of all, there has to be some kind of risk sharing. So each of the parties, let it be public or private sector, needs to have skin in the game. The second defining characteristic of PPPs is essentially that we are talking about medium and long-term contracts. When we look at contracting arrangements, on the other hand, very often, at least when we look at Thailand, for example, these contracts have a very short time period, maybe only 1 year. But for PPPs, we are looking at medium-term to long-term contractual arrangements. The third defining characteristics of PPP is that we use some kind of performance-based indicators that are mutually agreed upon. And then the third or fourth point is that typically under a PPP, the government owns the assets at least at the end of the contract period. So these are 4 characteristics that make a PPP different from other policy tools. Yeah. So the risk sharing, the long-term arrangement, the key performance indicators, and last but not least, government ownership of assets. So now I'm set up again. Okay. So why do we use these PPPs? What are the expected benefits? So for the PPPs, one of the main initial drivers was to enhance healthcare infrastructure. Let it be an outdated hospital, let it be a medical center. So upgrade infrastructure is one of the key drivers behind PPPs. We also use PPPs to improve the management of healthcare facilities. So again, we're looking here at integration of healthcare services. So particularly important here is functional integration. So through PPPs, we can improve the management of healthcare facilities. We can improve IT services or human resource management. We can also use PPPs to improve and expand services, especially when we look at a PPP that combines infrastructure-based elements with the delivery of healthcare services. So the objective for this kind of PPP more generally is, of course, to integrate healthcare services, and often they focus on the organization of care, integrating different levels of healthcare service delivery, so primary care, secondary care, tertiary care, or also horizontal integration. And then, of course, what PPPs allow the parties to do is to basically access private capital. So these are the main drivers of public-private partnerships. Now, how is a PPP typically constructed? So who are the key players? We know that already, the public and the private sector. But how does this contractual arrangement actually look like? Here I draw on a report by PricewaterhouseCoopers that nicely shows a basic structure of a PPP. It doesn't have to look like this. Bear in mind, please, that there are many different types of models. But essentially, it captures the key setup or the key elements, again, of such a PPP. At the center of this PPP are the 2 partners. So that means the public partner and the private partner. the private partner, depending on the complexity of the PPP, consists of several private partners that get together in a consortium. And this consortium then sets up a special purpose vehicle, a company to administer the PPP. So we see we have here the public partner, so the owner of the asset, let's say the land, let's say the public hospital, or at least the owner at the end of the project. And then the special purpose vehicle that pulls together the private partners. Now, depending on the model, there may be involved financing. So we have lenders. There may be a bundle of services ranging from construction maintenance to complete clinical operations. So typically, if we focus on infrastructure-based PPPs, we are looking at services like construction services, maintenance, equipment, and IT, and perhaps some non-clinical services such as housekeeping, catering, and the like. We may have clinical support services like diagnostics, lab operations, and as I said, full clinical operations. We may have sort of silent equity investors. So these are the ones down here. Now we see that between the two partners, public and private, the public partner receives the services, however these are defined, and in return makes payments. These can be payments for the use of the infrastructure, payments for the healthcare services, perhaps in the form of a capitation payment. So when we look at it, the PPP essentially turns a public asset like a clinic, a hospital, into a stream of services. For example, the use of a facility. So that's the we have the services, the bundled services. So it depends here on how the PPP is being arranged, what model we are looking at. And of course, the risks that are being shared. Again, that was one of the defining characteristics of a PPP I mentioned before. There are different types of risks, construction risks, for example, maintenance risks, risks associated with the delivery of healthcare services, and so on and so forth. Of course, a PPP does not have to look exactly like this. If there is only one private sector partner, then a special purpose vehicle is not needed. So this is a representation of one of the more complex forms of PPPs, perhaps where we combine a full range of services here. Yeah, so that's the basic setup of the PPP. Now, let me use this as a basis to explain some of the common models that we see that have been used around the world, starting with a very basic infrastructure-based model. So this is the one that started in the UK in the 1990s. I think most of you are familiar with this kind of PPP model. So here at the center is the construction of a healthcare facility. In the UK, these were hospitals. So because the facility takes center stage, we call it also a facility and finance model. I will go into more detail in a second. Now, the second model is a clinical services model. So here we focus on specific clinical services, like, for example, diagnostic services, dialysis services. So here, this is a model where the services are delivered at a public healthcare facility based on a contract with a private sector partner. Again, this is very close to contracting, right? But bear in mind, for PPPs, we're looking at a long to medium-term relationship, not at only one-year contracts, and most importantly, the sharing of risks. Yeah, but I admit, if you look at the different examples the distinction between contracting or outsourcing and the PPP model is often very blurred. Yeah, so this is fine as long as we are aware of this. So this focuses entirely on the services that are being delivered. Now, the third model combines essentially the first two models. So that means the third model comprises the infrastructure element and second, the service delivery. And not only non-clinical service, but full healthcare services, full clinical services, possibly also clinical support services. So these are the three main types of PPPs. There is a fourth one, that's the co-location. What's a co-location? Under a co-location, the government, the public sector, may allocate part of the land or facility to the private sector so that the private sector can use it to deliver specific health services. So, for example, we see this in Thailand at least, or in other parts of this region, where we have the public hospital that operates a private wing. So that's an example of a co-location. Or you have GPs that are located in a public hospital. Or you have a public hospital where a private sector provides the diagnostic services. So these are all examples of a co-location. So we have a public partner and a private partner that is co-located. Again, to be able to call it a PPP, there should be a sharing of risks. It should be a long-term relationship. We should have key performance indicators and so on and so forth. But in reality, again, for the co-location, very often it's quite difficult to clearly delineate the models. The important thing, however, is in how far we can use these models to enhance the integration of healthcare services and overcome some of the shortages that we see in the healthcare systems. So what I would like to emphasize is there are definitional gaps, and sometimes it's not straightforward to classify approaches, but that's not necessary if we understand the key characteristics and if we know how to use these policy instruments. Now, let me go a bit into more detail, focusing on three of these approaches, namely as an introductory model, because I think most of you are familiar with it, the facility and finance model. And then I move on to the combined or integrated model that combines infrastructure with the health service delivery and the co-location. The reason that I focus on the combined model and the co-location model is because both models are often used to enhance integration of healthcare services. Now, let me start with the infrastructure-based model. So we have two partners, the public and the private partner. Under the infrastructure-based model, the objective is to perhaps build a new facility or upgrade or renovate an existing public facility. So the private sector is basically entering this partnership to finance, typically, design, construct, and maintain the new facility. So you see, we have a bundle of services that we expect the private sector to deliver. So we from a public sector perspective. In some cases, the private sector under the infrastructure-based model would also provide non-clinical services, especially housekeeping, catering, and the like, or clinical support services. But the main healthcare service delivery remains public. So that makes this model different from the combined or integrated model. Now, under the infrastructure-based model, the public sector manages the hospital, as I've just said, is in care of the delivery of the full package of healthcare services. and makes payments to the private sector for the facility, right? So again, the public sector avoids the upfront payment and instead converts these into a stream of payments that are made in the future, yeah, for the facility, because this is the infrastructure-based model. So the most common examples are those from the United Kingdom, as I said before. They are known as the Private Finance Initiative. That was the first round that was set up. But given some transparency issues and dissatisfaction with the first round, a second round was set up, the Private Finance 2 initiative, which has already been phased out. The model is also known as a Design, Build, Finance, Maintain model, or DBFM. Yeah, so this classification that you might have heard before is based on the functions, the services that are being delivered. Again, there are different names for the PPPs. So I use the one or the classification that's based on functions, meaning here the services. What are the goals of such an infrastructure-based PPP? So the initial objective of these PPPs was essentially to enable the public sector to build new facilities or upgrade existing facilities without having to put up an upfront investment. So given the tight situation of many government budgets, the idea was to defer the capital investment. So turn the investment into a stream of phased payments. So the key goal is to defer the capital expenditures and encourage private investment. Now, the goal was also to transfer risk to the private sector. So the private sector is subjected to less regulatory oversight and therefore more flexible. So the risk surrounding the construction, like construction time, cost overruns, maintenance, is entirely shifted to the private sector. So bear in mind, PPPs, we have a risk transfer. And because of the better experience of the private sector, it was hoped that one can also obtain better designs that facilitate perhaps also the healthcare integration. So these are the goals of an infrastructure-based PPP model. What's the evidence? So in the UK, more than 140 of these private finance initiatives were actually set up. As I said before, they have been phased out. So they were rolled out on a quite large scale. That is because the initial results were quite favorable. So what does that mean? Of course, upfront funding is not required because we spread the payments over a long period of time, 20, 30 years. The built assets were delivered on time at the agreed upon cost. So all that worked well. However, with further evaluations, one realized that there were certain issues and concerns, especially value for money concerns. So whether the benefits would actually outweigh the costs, and there was no evidence of innovation. Yeah, so while initially they were viewed favorable, they turned out to be quite expensive compared to a purely public sector alternative. So that's the key reason why this form of PPP eventually was phased out in the UK. Now, what about the combined PPP? So this is the model where we combine the infrastructure element with the full service delivery. So the goals are similar to the facility and finance model, but on top of that, the additional goal is to improve the management of clinical service delivery, because under the combined model, we have both infrastructure and the full delivery of healthcare services, let's say in a hospital or a specialized clinic. So more specifically, of course, with this model, it is hoped that one can improve access and the quality of care, and of course also achieve further integration of healthcare. There are many examples in Europe of this model. However, again, when I look at the literature, I decided to choose the model that is most widely known, the so-called Alzira model, a model that was used or introduced in Spain, the region of Valencia. And I'll quickly synthesize the key lessons learned from the so-called La Ribera hospital. So this was a prototype of a combined or integrated PPP. So there were in fact two types of contracts. A first round that was terminated early because the contract didn't work as anticipated. Combined PPPs are very complex because not only do we have the infrastructure project finance in there, but also the delivery of health services that are very difficult to capture contractually. So under the first Alzira contract, a 10-year concession was granted by the autonomous region of Valencia to build, finance, manage a new public hospital. So this is essentially the infrastructure component that I mentioned earlier. And then not only to construct and finance that hospital and do the maintenance, but also deliver the entire health services. Yeah, so combined model. Now, given this complex package and the sheer size of the project, there was only one bidder. So that was a special purpose vehicle that comprised a consortium of private sector partners. So the name of that special purpose vehicle is Ribera Salud. So that's the SPV, the entity that is in charge of the bundled services. So the government had to make payments for these services. These were contractually arranged as capitation payments. However, the problem was that these capitation payments were set far too low. So this project didn't work very well because the private partner accumulated losses. However, I have to add that the private partners, those who participated in the consortium, were among others, regional savings banks with very close ties to politicians. So there were governance issues right from the beginning. So what happened to the first contract was that it was terminated prematurely and the compensation was paid to the private partner. This in itself was very controversial. Again, governance questions came up. Now, the contract was first terminated and then re-tendered under new conditions. So that happened in 2003. And this is the part that's most relevant for this course, because under the new contract, let me call it Alzira 2, essentially what happened is that the scope of the contract was widened substantially. So not only the hospital, but now under this contract, we looked at an integration of all levels of care. So that means primary care centers in the area, newly set up integrated care centers, and in some of the areas also long-term care and social care. So the full package. In addition, apart from the expanded scope of services, also the contract duration was much longer. And of course, given the problems and the experience with the first contract, the capitation payment was set much higher. So again, some positive results initially, but again, there was a lack of independent evaluations. So the lack of transparency is really an issue that has a bit haunted the PPP experience worldwide. So nonetheless, despite these concerns, this model was widely replicated in Spain, but also in other European countries. However, the original Alzira 2 model, so meaning the extension of the contract, was ultimately ended in 2018. Why? Simply because the doubts that had been lingering around for many years have never been fully addressed. So these were primarily financial doubts, or whether it's really value for money, but also doubts regarding the governance of this model. So the bottom line here is, and I think by now you get a good sense of it, one has to look very carefully at the PPP models. They have a high potential. So if you look simply at the scope of the services package and the potential for achieving an integration of healthcare services, also functional integration, because what the private sector did was essentially completely integrating IT, integrating all medical records for this particular area. This has a high potential, but then the other issues need to be addressed as well. Most importantly, having convincing independent evaluations. Now, coming to the third model, and here it's always debated whether it's really a PPP model or not, because very often it doesn't entail the amount of risk sharing or a shared investment. But nonetheless, I include it here simply because some of the literature considers it a PPP, and second, it has a very high potential for healthcare integration. So the co-location, what are the goals of a co-location? In a nutshell, the goal of a co-location is to utilize real assets of the public sector better. So you have an existing asset and you can get out more by allocating some part to the private sector and then receiving either a payment for this land or asset, or you receive services in return. So that's the main goal of this kind of co-location. Of course, with a co-location where you have the public and the private sector next to each other, you can also benefit from the private sector expertise. So we have seen co-locations, especially widespread in Australia, where we have co-locations of public and private hospitals. What's the benefit of this? Like with any agglomeration, you have automatically a sharing of staff, of inputs, you have a sharing of know-how, you may retain specialists within this large complex. So you have these common agglomeration benefits that really make this model very attractive. It has been shown to have a potential to increase out-of-hospital care, especially if you combine health and social care. And then, of course, ultimately develop integrated care systems. Some examples, for example, you could have community health centers where you have public health, but at the same time co-located a private sector that provides diagnostic services. Specialist centers where you have multi-specialty professionals working next to one another from both the public and the private sector. So this gives us specifically the agglomeration benefits I've mentioned earlier, also simply to retain specialists within an area. And what I mentioned at the beginning, the co-location of GPs within local hospitals, like, for example, in the UK. So these co-location initiatives are relatively straightforward when compared to the more complex models of PPP, like, for example, the combined or integrated model. Yeah, they have a very high potential, especially in terms of the 3 examples that I put down here. But bear in mind, there are different examples of co-location, especially the private wing that I mentioned before. So in Thailand, this exists in some places. And in Australia, the co-location of public and private hospitals. You can realize from an economist's point of view, of course, economies of scale and scope. Now, this was a quick review through some of the important models of PPPs. Let me just synthesize a little bit what are some of the key lessons learned from the literature. And again, we apply that to the case of Thailand in the second part. So first of all, looking at the infrastructure-based models, again, like the ones in the UK, the private finance initiatives, the first and the second version. So overall, the literature clearly shows that this kind of model has not met expectations for achieving greater efficiencies. They are generally considered to be rather costly. And also the lack of innovation, perhaps because of the tight contractual arrangements, was quite obvious. So this is based on a 2013 paper by Barlow, Werish, and Wright. Another observation is that the combined models that combine infrastructure and the full delivery of health services have a much greater potential, especially with respect to health services integration. We have seen that in case of the Ribera Hospital, the example that I went through. But as this example has also taught us, it is also a model that's very complex and requires a lot of capacity on both the public sector and the private sector side. The clinical services models, so that's the model where perhaps the government has the hospital and brings in the private sector to manage this entire hospital, as well as the co-location models are much less complex. So therefore, perhaps easier to implement, but that depends on the context. So my colleague will talk more about the context in Thailand later on. So rather than perhaps jumping into a combined model in terms of the learning curve, it might make sense to start perhaps with clinical services and co-location models, both of which typically have a much shorter duration. So bear in mind, for infrastructure-based models and the combined models, we're looking at very long-term contracts, perhaps up to 30 years, 20 to 30 years at least. For the PPP projects, especially infrastructure and the combined model, as I said before, there is a lack of long-term evaluation. So many doubts have remained, and that resulted in these models having been phased out in some countries, as I explained earlier on. Nonetheless, if we look at the situation in many healthcare systems, let me also underline that PPPs are an interesting policy tool. They do have a potential, especially also in terms of healthcare integration, and therefore should be considered. Now, what are some of the factors that could make such a PPP successful? So very important is political will and a commitment. So this is a lesson that we especially learned in Thailand, where there were or are still many PPPs in the pipeline, but haven't progressed far. Equally important is a supportive legislative and regulatory environment that actually makes this kind of model feasible in the country context. Both the public sector and the private sector need to have sufficient capacity. As you could see from the few examples I gave, the PPP models are very complex, and they incorporate a lot of uncertainty because the planning is for the long term. So again, we're looking at contract durations of 30 years. So where are the uncertainties? So properly estimating future costs, especially for the public sector, and assessing the capacity of being able to meet these. Having a strategic plan for investment decisions. This is particularly important when conducting the bidding for these PPP projects, and of course, the contract management. We have seen in the case of La Ribera that the initial contract didn't work well, had to be terminated and then re-tendered. For the contract design, given the very long time period, it's very challenging and impossible to capture all the risks and to cover all the eventualities that might occur. So one has to have experts that can deal with this complexity. Stakeholder engagement is very important. This morning we had a presentation on accreditation where this was emphasized. So therefore, I didn't go into detail, but let me just add that the model that was used in Spain was very controversial and debated because many of the public sector staff basically had to change their compensation from a civil service compensation plan to a private sector plan, which was less generous. So that, of course, was extremely challenging, not well communicated. So without good stakeholder engagement, these difficulties cannot be managed. Then building partnership. It's a long-term relationship between the public and the private partner. So it needs to be maintained. And last not least, and the reason that I put it last is because I think it is really at the core of many of the issues we have debated, is one needs to ensure transparency because stakeholders need to understand the models and need to see what are the costs and what are the benefits. Again, if we look at the example that I cited from Spain, given the close relationship of the regional savings bank with the politicians, it was clear that the costs that were used in evaluations were not the actual costs. So therefore, this gave rise to governance issues and the whole project didn't work out well. So I think this is as far as I would like to go. I would now like to hand over to my colleague who would share the practical experience of these issues. What I presented was a synthesis of the literature. But we have made a lot of experiences in Thailand. There are several health projects in the pipeline. I've listed here some of the most notable ones, like specialized medical centers, again, to benefit from agglomeration, to enhance health services integration, the medical services buildings, the infrastructure component, and clinical support services. So let me leave it here and thank you for your interest. If you have any questions, let's wait for the Q&A after this session because it's a shared session. Then I'd be happy to elaborate on any of the cases or answer any questions. So thank you very much.
Okay. Can you hear my voice? Okay. Thank you for my colleague, Chong Tao Teacher Salai, late night yesterday. We actually have done lots of work for public PPP project for Ministry of Public Health that I would like to share with you. If you feel that, oh, this is a really good way to pick up the tools for policy makers to just, if you would like to integrate the healthcare system in your country and you look for policy tools and you think that, oh, why not pick up PPP? First, I would like to share to you how challenging it is for the PPP project. So you have this that I can change the slide. Oh. Not move. Oh, this, yeah, okay, thank you. For my actually for my session is let you understand the primary care system in Thailand, the reform and challenges, how to strengthen and engage the private sector. And second, to understand the key characteristics of hospital PPP models in Thailand, the obstacles and lessons learned, and to reveal the strength and weakness of PPP models. So far, when you talk about the PPP, infrastructure-based model or combined model, or with the co-location model, or PFI model, for Thailand, we attempt to do. The problem is, as I said earlier yesterday, that in the health system, you cannot just only look for the health service delivery system that you use PPP to arrange for that on the health services delivery system or services to the patient. But the most importantly on healthcare financing model in your country. That what Chita already mentioned to you, that look for that what is the resources for your healthcare system. Because in Thailand, when we got stuck for the PPP in the pipeline, still in the pipeline, because of the payment, how can we arrange the payment under the PPP project for Thai? So for Thai that, I don't know how to move the slide. Come back to this that my colleague already presented to you. I will skip. And first on the Thailand, that when you look in this on this table, we have the problem of the population age over 65 years. In 1970, it's 3.1 and will be like 8.9 in this year. And then we have the problem of the aging. And then you look at in terms of population age 80 and above, 2.5 in this year will be 1.7. It's scared, right, to the policy maker. Our population growth 3.1 this year, only 0.5. We will be an old country, right? We are not a young country anymore in this year. So we have to think how are we going to provide enough health services to the entire population. How can we engage the private sector at least for primary care services? And perhaps look for the hospital PPP for some specific services. And for this, that we have death rate, like for 9.7 to 7.4, or the proportion of a single person, right? 5.0 in this year, almost 15% in this year, 2010, and maybe more, meaning that we have more of a single person household. People do not want to, they want, of course, right? But they do not want to marry. They do not want to have actually children. Many of the couples said that they don't want children. They want to be independent. So who will take care of them? This is our problem. And adult literacy rate has been improved so much. This is our Thailand health system. We have Ministry of Public Health. We have our National Health Security Office, run for yourself health coverage. And this is on Thailand health system. And for talking about primary care, we are going to look at this bottom. Now, under the decentralization of Thailand, that community and the community-based healthcare provider for Thailand will be now transferred for Ministry of Public Health to Ministry of Interior. So this is timeline for primary healthcare development in Thailand. In Hong Kong, you said that you start for 30 years. For Thailand, starting in the year 1932, and then this is our journey. Actually, this is start Community Primary Healthcare Center in the year 1991, and then to this. How many years? Almost 100 years. We just start to have primary healthcare act particularly, right? I'm not sure that in your country you have this act or not, but Thailand just have this primary healthcare act. The attempt is for what? Because of that act, we are going to decentralize the healthcare system for Thailand. So this is the first decentralization action plan. Starting in this year, when we start to have our universal health coverage, starting in the year 2000, and then in the year 2010, we upgrade health center to sub-district health, promoting hospital and paying incentive for voluntary health volunteer. During this time, only the evolution of 28 health center to Tambun, I mean that sub-district level municipality, they moved to under the Ministry of Interior. It took us for 10 years, 28, right? But surprisingly, this year, there will be 2,000 health center we transfer from Ministry of Public Health to Ministry of Interior within 6 months. You know why? Political commitment that Chong Tao said on PPP that you need political commitment. This is because we have new government. And Minister or Ministry of Public Health in the former government, he moved to ministry to be the Minister or Ministry of Interior. You know the reason why we can move transfer the more of the community health unit to under Ministry of Interior. What about this? In the year, this one is similar to Hong Kong that you have more of the hospital and less of the rural health center and community. And this year, Thailand can expand the rural health center. We have more of the rural health center and community and private clinic provide primary care. And we have less of regional health, right? At this, and in which I think that in Hong Kong, you attempt to do this one, but perhaps not sure that, but for Thailand. And we have more and more of the rural health center, and then we have less of the in proportion for regional and general health hospital. With this one, this is on why Primary Healthcare Act in Thailand chaired by Health Minister. And that's why we plan to build family doctor team, including multidisciplinary officer and village health volunteer. For this one, care for 10,000 persons per team for what can benefit this bar in 10 years, right? And decrease preventable disease, hospitalization, and disability, reduce waiting time, save travel and other expenses. According to this act, this is our local administrative office, right? We have private hospital here, private clinic, and community health and services. At the regional based health services system is this one. Right? So with this, I will skip this one. Create the family doctor team to primary care cluster. 3 family doctor team per 1 primary care cluster, and apply family medicine process. Strengthen district health system and district health board. Integrate to service plan to referral system. PPP Thailand are under this service plan. So This is the story for Thai. This is plan to build more of family doctor. This is primary doctor production plan in 10 years. We should have this to provide primary care for the entire population. And this is for what the pyramid like. We have excellence center, tertiary, hospital, secondary care, hospital, primary care, hospital, and community. So in this, in totally hospital bed, the Ministry of Public Health own about 65%. As a public, 14%, and private own 21%. But service providing is in totally Ministry of Public Health 80%. And private only 10%. And this is the population per doctor decline, right? It looks good. This is nurse and this is doctor. We produce more doctors. And this is on under decentralization. This is percent as compared to government revenue. So you can see, right? This is the money, the budget you allocate directly to the local administrative, right? In terms of this, account more than 25% of the government revenue plan up to 40% had to be allocated directly to the local administration. And this is for 4-level model, like this is have patient, care team, organization, and environment to integrate. And this is for that we have this of the model. Primary care team continue as comprehensive and person-centered care. This one, right, in community. And we have to primary care goals and link with other healthcare unit. Right? And this is why we call for healthcare integration. This is on community health fund. We have local government budget allocated directly from the central government to local authority. And ANHSS will allocate some fund to this for particularly for the health, primary health care and elderly care, particularly for elderly in this. And this is on primary health care, like health promotion, disease control, healthcare rehabilitation, and consumer protection. From this one, this is on some education, but networking partner with the rural general hospital, district health, office health center, village health volunteer, local administration, private organization, temples, and schools. So this is an example one. This is just recently for under when we start to decentralize. General hospital, because of this, they are not under the Ministry of Public Health, they are under the Ministry of Interior. Then we need to have this networking. So you can see on the, that is a problem because our health financing is like this. We have this one on universal health coverage, social health insurance, and CSMBS. The legal framework for UCS is we have National Health Security Act, Social Health, we have Social Security Act in the year 1990, and Royal for CSMBS is Royal Decree 1980 and recent amendment in the year 2010. Type of organization, UCS is autonomous public agency. Governing board is they have 31 members chaired by public health minister. Even though Thailand use split model between purchaser and provider, but minister or Ministry of Public Health, they do chair the executive board of the UCS. And SHI is like for chaired by permanent secretary of the Ministry of Labor. For CSMBS is advisory board, 19 members chaired by permanent secretary of the Ministry of Finance. We are not have a single pool, right? We have to purchaser. And this is just the link. So private healthcare provider participation in UC because of this reduce crowding in public facility, maximize the use of existing resources, increase efficiency of health service, and government doesn't need to invest in new infrastructure. Even without PPP, you engage the private sector because government doesn't need to invest in new infrastructure. And this is the benefit. Increase access to service, reduce crowding and referral problem. And when this is the role of the private sector, still have the problem of referral problems. And that's why we call for integration. And health promotion, disease prevention in Bangkok still lack coverage. Private sector withdraw from the service network and even distribution of service units in the urban. Then you can see that number of private hospitals under UC reduced. Number of private hospitals under social health insurance decreased as well, right? Why? You're not interested in? And that's why we need to prepare something in order to engage the private sector. And this is the problem in healthcare provider in Bangkok. Compare hospital, private, this amount, and then you see only this. Primary care clinic, we have at this number 4,000. Only 171 want to participate with UC. Dental clinic and drugstore are all private. We do not have public one. And only this under UC, right? We do not be able to engage more of the private sector to provide service for our UC beneficiaries. Now, so following the introduction of UC, Mr. Public Health Hospital have been contracted as CAP to provide essential health service to people residing in the district. And UC, particularly UC budget channel through CAP. And this is the problem. This is an example of the contracting unit for primary care. This is not because of Ministry of Public Health. This is arranged by the ANHSS or National Health Security Office as the purchaser. Not confuse you. Ministry of Public Health, they said primary care cluster. ANHSS will contract to the primary care unit. So primary care unit that they call contracting unit for primary care. But we see public health never call. Never call. If you read in the report of Mr. Public Health, they call only primary care cluster or unit. They did not call CAP. CAP is for financial arrangement. And this is that what EK present to you on integrating care system framework for policy instrument and this macro, meso, micro, like that one. So for us, Thailand, we have national health policy function, strategic purchasing of integrated care, financing for sub-district level community fund, and etc. to governance and implementation, regional health office, provincial health office, and then to this end user of integrated care in district health system, patient with multi-morbidity, caregiver and family member of the patient. So this is on for discussion. And you can discuss on this kind how primary care organized in your region, what the main challenge, etc. What is the involvement of private sector in the health system? So with delivery system in hospital actually doesn't sufficiently support patients with disability or is the continuity of both medical and social care within communities. This is our problem now. And that's why we discuss on hospital PPP. Now, let's skip this one. Actually, I and Chong Tao work on typology of form of private sector engagement. It's not to be only hospital or health facility. You can look for public health and social program or service or health facility. That Chong Tao already present all of this to you. you can do for this clinical service as well that we can call. And in Thailand, we have many of form of public-private partnership we call, like design and build, or DBM, DBO, DBOM, like DBFO, like that one, design, build, finance, and operate. But for most of the hospital PPP in Thailand, we use this model, build, transfer, and operate. Build, meaning that infrastructure-based model, right? Transfer to the government, transfer to the Ministry of Public Health, and private operate. BTO, right? And then we have like this one, but this one mainly used for the infrastructure project outside Ministry of Public Health. Now, this is the difference between outsourcing, purchasing, and PPP. PPP, my colleague already presented, but we have contracting non-clinical support, contracting clinical support, contracting specific, or even buying hospital services, outsourcing or purchasing. And hospital PPP in Thailand, we use some of these service or facility and finance or combine is not yet. That's only planned, but not yet. And co-location has been started in some hospital. So this one. The goal also with PPP, transfer risk. The problem for, I think that not only Thailand, public sector never take risk, never take any risk. The contract, they push all the financial risk or all the risk to the private one. Because the public can no longer be able to take the risk. If they sign the contract, that person might be under investigation, maybe later on when they step down the position. And that's why this is the main obstacles in the PPP project to sign the contract. So this is, as I said, that we have this on Private Investment in State Undertaking Act, the year 2013, we call PISU Act. And we have Public-Private Partnership Act in the year 2019, we call FAST, Facilitation, Alignment, Streamline, Transparency. And with this plan, this year, we are, the Ministry of Public are under Group 2 subsector. Government encourage participation of private sector, development of public health infrastructure for health and elderly care facility, specialized medical center to medical service center, and including car park. Don't supply for Thailand. All hospital, public hospital do not have car park building, and now it's a problem. When they submit the proposal to Ministry of Public Health to build the car park. And this is quarantine center. And development of pharmaceutical and medical equipment facility. For example, high-tech radiology, the diagnostic service center, hemodialysis center. Hemodialysis center, and this one can be part of the primary care. Can be hospital-based or maybe independent. And this is one is budgetary, operational, and institution. This one is what first on this one. I think that at the back cannot see. I work with Jan Chong Tao for office for the responsible agency, office of permanent secretary of the Ministry of Public Health. They do have the project for medical service building and car park, and specialized medical center, and specialized medical center and car park building again in another province, and specialized medical center, right? or quarantine center is for the Department of Disease Control, will not work for them. And another tool is for high-tech radiology diagnosis service and hemodialysis service for patients with chronic kidney failure. This is in the pipeline, right? And this is estimated total investment in million baht. Current status is PPP identification for this, but for all from the Office of Permanent Secretary is PPP preparation or PPP identification, and this on PPP preparation. May I share with you for this one is Specialized Medical Center for Department of Medical Service. This is the PFI model, private finance initiative. So the Department of Medical Service, almost 10 years already, still not yet implemented. But this is a medical, this is expected PPP scheme, right? In the year 2016, 2020, this is 2023, have not yet signed the contract. Expected PPP scheme. Private sector will finance the construction and preparation of all medical equipment, as well as operation and maintenance. PPP gross cost model, available payment contract model, they already have contract. And PPP contract period is 30 years contract. Okay. And total investment cost is this million baht. Expected private investment, this amount. So project background. Medical center comprises of a wide range of services and functional units, like inpatient department, IC, intensive care unit, coronary care, hemodialysis center, center of expertise and medical specialists from all institutions of Department of Medical Service, meaning Department of Medical Service under the Ministry of Public Health will be the one who operate. This is we call PFI, Private Finance Initiative, private bill, and then the Ministry of Public Health will manage and operate that facilities under the payment that they have to risk back to the private investor. I really look for this project because I know I was in the meeting with them all the time, many meetings. This is the situation of hospital PPP in Thailand. Actually, PPP in case of, sorry, but I have to use it because there is no any translation. In Thailand, because Rajapasadu land, and mean that this land belong to the state, belong to the government. Project value is this above this amount. PPP in case not in this land, meaning they might build on the land of temple, not government land, not state, then project value is less than this amount or can be above this amount. PPP in case of EEC project list. This is have meaning for Thailand because if it's not under this land act, it's more easier than use the land with the state land. It's very difficult to make the PPP for this one. So according to the PPP Partner Act in the year 2019, Section 28, principle of PPP project, you must address project objective, scope of the project, public-private joint venture project, which must be at least consist of duties and responsibility of public and private agency. You must have support measures for the joint investment project. The reason and necessity of private selection without using the auction method. And solution to problem and obstacle in case of problem and obstacle caused by the laziness of the relevant government agency. All of it you need to have that document, must have this document. But under the EEC, this is the newly, the PPP in case of EEC project list, EEC is Eastern Economic Corridor Act 2018, comply with the announcement of EEC Development Policy Committee guidelines, matters, method, condition like this for private investors. So Ministry of Public Health, they use this opportunity to build, to start the PPP, hospital PPP under EEC project. So this is for what promising clear regulatory and governance structure. Prime Minister of Thailand chairs the EEC Policy Committee. The EEC office received full support from the government with a distinctive regulatory and governance structure. An integrated infrastructure is being developed for EEC. So to become like a prime gateway to Southeast Asia and Asia Pacific in the coming year. Meaning, if you are going to build facility in with the EEC under with this for the EEC project list, if you have some obstacle because of regulation of the national regulation or law, in this project, the chair, because chaired by the Prime Minister, then they can move up all of that obstacles. And this why come with EEC project is accelerate the study of public-private joint venture PPP models and become a sandbox project to enhance the public health services by collaborating with the private sector. We call Prok Dang Hospital 2 project. We will support approximately 200,000 insured people in Prok Dang district. And this is what convenient, safe, quality, reduce travel to medical care outside the area, giving local establishment confidence that employees receive timely services from hospitals that meet provincial standards. So this is the first announcement from the Mr. Shatin. He is a Deputy Minister of Health by that time. In early of this year, he announced and made the press release, announced this project is considered a model for hospital expansion under Ministry of Public Health using PPP model. Total investment, this amount. And what they expect that this project will create financial benefit for the public sector over 50 years project. The amount was this million baht. Revenue from land use compensation amount to this baht paid to the public. Share of revenue from the private sector amounted to this baht. Right? Deputy Minister said. He said in this, but unfortunately, he is no longer as the Deputy Minister of Health because we have a new Minister of Health. So in the press release, top of the officers in the Ministry of Public Health, they stand beside the Deputy Minister, right? And announce this project, PPP, hospital PPP, already studied for financial feasibility and ready to call for private investor because this is private investment. So as plan is like this, build, transfer, and operate BPO joint venture. Private sector design, invest in the construction of essential assets and transfer ownership to the state immediately after completion, right? And it is supported by because of what? They have to transfer in order to be able to arrange financial arrangement You know that Thai people under the three main scheme, UC is a tax base. Social Security is a Thai party, right? And then, so with that CS and BS in another of the insurance scheme. So with that, it's not easy to pay for the health services because people do not want to pay out of pocket. They do not, because they know exactly that they are under some health insurance scheme. How to arrange those insurance schemes to pay for them. That is the problem why they have to transfer immediately back to the Ministry of Public Health. It is supported by the Special Economic Promotion Zone, comparable to the Board of Investment Privilege. For example, 8-year corporate income tax exemption. Otherwise, subject to 20% of the after for the not for after that, then they're subject to 20%. But 8-year corporate income tax exemption, marginally import duty exemption. You know that Thailand have to import all of the medical, the expense, the very high cost one for like we cannot produce ourselves, and tax exemption. So Ministry of Public Health will hand over land with a 5-story surgery accident build. Ministry of Public Health will allocate budget to build this 5-story surgery accident building, this worth amount, million baht, to the private sector for the construction of additional service building and furnish within 3 years and transfer them back to the office of Permanent Secretary of Ministry of Public Health. And this is, they already have, and then this one that will be built by Ministry of Public Health, additional building is by the private investor. So this is for what they plan, right? And this will become like a first PPP hospital in Thailand if a new Minister of Public Health do not terminate this project, because it took too much time to prepare for this project. Like they already, and they have 4 private investors who are interested in this project. And this is trend in Asia, right? Outsourcing purchase is common. Improvement in PPP enabling environment. Hospital PPP is increasing, considered but challenging, right? That Chong Tao already said, political will is all important. Engage stakeholders throughout, right? Involve users from the outset. When we did for PPP feasibility study, we have to engage particularly private investor to a meeting we call like market sounding, to see that you have enough private investors who are interested in that project. Make the project attractive to the private sector. Formal and informal relationship management based on trust, right? And focus on service planning rather than infrastructure alone. And develop an approach to determine value for money. Capability of the team is key. You need to build the capability of your team if you are going to do PPP in the Ministry of Public Health. This is key element. Regulation and registration, project initiation and tendering, stakeholder engagement and communication, financing and pricing. This one is the main obstacle actually for PPP project in Thailand, still in the pipeline. And risk allocation, performance metric, and governance. Actually, Thailand, we do have contract for, but that is contracting for the private provider for MRI services or CT scan services or laboratory automation. That is a private one who invest and build and provide services with inside that public hospital, but under contract. We have all of that already. We have some form, but not exactly like co-location, but we still think that we allow private provider to utilize and use some portion of the public hospital space to provide services. So this is, or have any this or other model be implemented in your country, right? So I will stop and then Chong Thao, would you like to come up for any of Q&A? Or you not have any Q&A? Yeah, please. Oh, no, I have to do that one.
Thank you for the presentation. I want to share Indonesia experiences a little bit and ask some two questions. I think, I think in Indonesia still rare in the health sector to implement the public-private partnership. But actually we have some PPP in the another sector, especially like infrastructure. But for the service, I don't know, in the health or another service, in Indonesia, and Indonesia always use the PPP model in bulk operate and transfer. And I'm just I want ask your perspective. There will be a transfer of ownership to public, especially to government after the contract is complete and their capital has been returned, right? In the BOT. In Indonesia, when a service become government property, the quality may decrease. Not same with the service from a private sector. Now, what the strategy should government implement to maintain the service quality when full ownership is transferred, and other country criteria to implement a PPP model. I think for co-location model is difficult to implement in low middle income country. Thank you.
Okay, thank you very much for this. This is very interesting, some very interesting questions. Let me work through them one by one, and if I forget any, please jog my memory. As my colleague said, I arrived very late this morning, or very early this morning, late last night. So a quick word on the classification that I think might be useful. The classification that I used of the PPP models, like a design, build, finance, etc., they are based on functions. Now, the BOT, BOOT, BOO, the whole range, the alphabet soup, it's based on legal ownership, if you will. So that's why the question about asset transfer is really important here, because it is inherent in that typology. So yes, by contractual arrangement, the ownership, it depends on the type of model, is to be transferred back to the government. But if, for example, you have a BOO, no T, no transfer, then of course in this kind of model, no transfer. So they're different models. So it depends on the contractual arrangement. So that's possibly my response for the first question. And later, perhaps my colleague would add on a bit. Now, regarding the second question, that's also a very interesting question, looking beyond the contractual
time period. And that's one of the problems. So many of the models are relatively recent, right? So that goes hand in hand with the lack of evaluation that I've mentioned. But one of the strategies one could use, if suppose the case that you have described, a decrease in the quality of the facility at the end of the project period, a possible response could be to simply enter a new PPP. Because if you look at the long duration, 30 years, so by that time, the healthcare facilities have become obsolete. So this is one of the key problems in Thailand. So the healthcare facilities, when they were built, were up to standard, but then over time, given the lack of investment, has resulted in many of these becoming rather outdated and obsolete. So hence the look towards the PPP model. So in the future, of course, this kind of model could potentially be used in its varieties. Yeah. Have I addressed your questions or did I miss them? Okay, thank you. Maybe my colleague would like to add on a bit.
PPP doesn't mean that after you sign the contract, the public will leave any of the responsibility to the private one. Actually, public need to monitor the quality of services. They must, and that always addressed in the contract. Also, why each party can terminate the contract. So in that sense, the quality always addressed in the contract. That is contract, you said it's a contract, not, but because of that is the way that the public can monitor. You must have a team to evaluate and monitor the performance. As you cannot leave just only the private to operate, live on their own. It's not just only to track only financial or the amount of money that they can transfer to the public one. It's not like that. Because this is patient center. The purpose is to provide good quality of services to the patient, no matter of policy tools.
Yes, please. Can I give you my microphone?
So thank you both professors for the excellent presentation. I learned so much from the lectures. I have a question based on the Hong Kong context. The biggest dilemma and challenge that we are facing in Hong Kong for PPP is that the more we engage in PPP, the more business we are actually feeding the private sector and the more brain drain that we are suffering from the public sector. So what is your view on this? Because doctors and nurses are, I think, the most limiting resource that we have in Hong Kong healthcare.
In Hong Kong is similar to Thailand because you are on tax-based, right, system. The way that you engage the private sector and you are going to start the PPP. So what the purpose of that PPP, what kind of the model for the entire services or some specialized services, or what type of the services that you have a plan for?
It's still at the budding stage. I think we have engaged the private for certain specialized services that have long waiting time in the public, and also a bit of general outpatient clinics consultation.
So maybe a very quick response. I'm not quite sure whether I fully captured your question. Let me respond, and if not, please let me know. So one of the case studies that I explained, the case from Spain, the Azira model, if you will remember. So they basically address this issue by integrating certain incentives into the contract. So essentially making sure that the profits do not become too large and are not too small. So that would perhaps address the desire of private business towards profit maximization, especially if they are shareholders. So essentially, the contractual mechanism was such that you know, the health area has a certain catchment area. So when patients from that catchment area went to another health district, then the cost had to be paid by the PPP hospital. You had to avoid that patients move to another area. And on the other hand, if people from another area move and receive healthcare from the PPP, there was also a penalty, a lower capitation fee. So you see, there is no sense in attracting too many people because the capitation will be lower and hence the profits will be lower. So to answer your question, I think one has to find a contractual mechanism that keeps the profits reasonable, if you will. Regarding the staff, that's always challenging. So Thailand is experiencing the same shortages of certain specialists in some areas. But I think if you look at the co-locations, these particularly make it attractive for specialists to work together because you have knowledge transfers, you have a pooling of expertise in a geographic area. So that might be an interesting model to use these multi-speciality centers and sites to be able to retain staff and potentially attract more staff. But okay, thank you. Oh, time up?
Yeah.
Not sure
Okay,
whether.
thank you.
Okay, thank you very much. Thank you.
What's my name?
If you have a question at lunchtime, you can find any our speakers downstairs and then feel free to ask them questions. So now we move to the lunchtime. The lunch are ready right now at the foyer, first floor, ground floor. Yeah. So enjoy. Yeah, we will come back at 2 p.m. for the afternoon sessions. We'll see you.
Recording stopped.
Okay, I wrote this paper with my colleagues, without service, but he is not here in Indonesia, and also Miss Kia, Miss Ayu Puspandari, she's here. So she will discuss on one issue on how the innovative way of making or pushing the doctors becoming more active. Okay. So let's go to the framework. So we are here in purchasing, yeah, in one of the government policy instrument, how to purchase. And this is if look at back to the discussion yesterday, we discussed about financing, okay, governance, and also Prof. Utarini this morning as well about regulation and legal mandates. Now I'm here for purchasing. Okay. So this is part of the head financing functions. The third part is purchasing and payment. Yeah. And there will be three cases we'll discuss. But before, I would like to have the concept of purchasing and it's so-called strategic purchasing. Strategic, so what does it mean? Let's do some introduction discussion first before we go to the case studies. The case study number one is about strategic purchasing in health insurance in 2017. And then case number two is trying to integrate the payment between BPJS and government in public health programs, case of PP. And then case number three, a proposal for pay for performance. And this is the innovative way of doing strategic purchasing. Okay, now let's go to the concept first. This is the definition for purchasing that involves three sets of decision. One is a long sentence, identifying the intervention of services to be purchased while taking into account population needs, national health priorities, and cost effectiveness of those interventions. So we can see that this is done by the purchaser. Yeah. And then two, selecting service providers, public or private or mixed, giving consideration to service quality, efficiency, and equity. And then determining how services will be purchased, including contractual arrangement and provider payment mechanism. So purchasing refers to the mechanism used to secure health services from public or private providers, and this should be like seamless from primary care to hospital care. This is the idea or the ideal situation that we are going to achieve. And then one critical factor is the extent to which purchasers are able to influence providers to pursue equity, efficiency, and quality in health service delivery. So we can imagine that purchaser maybe one unit or organization, but this organization has so many providers. For example, in case of Indonesian's health insurance company, the primary care, it can be 24,000 units of primary care, and then the hospitals about 2,000 hospitals, yeah. Public or private. So you can imagine how the problems of making the services becoming seamless from primary care to hospital care, because it can be done by the primary care is private, but the referral is going to public hospital, or the other way around. The referral come from public primary care, and then the patient is referred to a private hospital. So different way of doing referrals. So that's why quality is very important. And this morning, Prof. Utarini mentioned about accreditations. how the accreditations of the primary care and the hospital. Is there a standard for services or input of the services? This is the things that purchasing is concerned about quality. Okay. So look at this box, actual purchaser here, and there is a link with healthcare providers, government, and citizens. Yeah. So there's a separation between government and purchaser. But in, say, in Hong Kong or in the British system, maybe the government is also becoming the purchaser. Yeah. But in Indonesia or in Taiwan, the budget comes from the government. But because it is split or separated with the purchaser, the budget will be given to purchaser. So the government, they have to have established clear frameworks for purchaser and providers. So this is like regulators of the system. And then the government have to fill service delivery infrastructure gaps. We do understand that it is impossible for every district, the private sector or the government organization can do that. So that means the government still fill the gaps from the central if there is a blank spot of services in one district. And then ensure adequate resources localized to meet service entitlements and ensure accountability of purchaser. So this is the government role for purchasing. And then also citizens. This is like the object or maybe the target of services. So they have their needs, preferences, and values. And then they have to be informed. And then have to have access to services. Yeah. And then establish mechanism to receive and respond to complaints and feedback. So they have like the position of in the driver's seat, not only recipient, but they can have like a complaint management system that can be used for increasing the quality of services. Okay, and then publicly report on use of resources and performance. And then the link between purchaser and healthcare providers, and this is the chunk or the big interest of purchasing is about how the contractual arrangement or the selection of the providers by the purchaser. So there's so many things here, like select providers considering range, quality, and location. So that's why in terms of quality, if the provider they don't have accreditations, health insurance will not working together with the hospital. Okay, and then establish service arrangement, develop formularies and standard treatment guidelines, establish payment rates, secure information on service provided, audit provider claims, and then monitor performance and act on poor performance. Because the main things of the purchasing is how to make the quality of the services purchased is good. Yeah. And then protect against fraud and corruption. Yesterday I discussed about the fraud and also corruption. Yeah. And then pay providers regularly, allocate resources equitably across areas, establish and monitor user payment policies, and develop needs and use information system. So these are the things that purchaser they have to do in purchasing system. Okay, it's a lot of things that they have to do. And then there is like a jargon of passive and strategic purchasing. Strategic purchasing is different with passive. Because actually, if we look at this allocation based on norms, yeah. But in the strategic, the payment system that paid to the providers should create incentives for a higher quality or a better work. Yeah. And then there should be like a power for the purchaser to select the contractors, for the providers, yes. And then there is a quality improvement and rewards. And the strategic purchasers, yes, they have to have the what we call like the authority or the position in making the price or quality, not influenced only by the providers. And this is becoming important that if the providers is only one, that means there's a monopoly of provision in one area. So that means if we are going to have like a strategic purchasing, there should be many candidates of providers, not only one, and the purchaser can select which one is the best providers to be contracted. And this is the terms of strategic purchasing. The objective is about the social justice in the distribution of resources. So we have to have the best use of resources. Efficiency, the use of hedge funds. Yes, yesterday we can understand that from the macro policy, we can go down to the micro action, and then there are so many causes for inefficiency because the behavior of medical doctors or hospitals. So we can see that super induced demand or excessive referral, many things there. And these are the efficiencies of the use of hedge funds. And purchasers should make this becoming more efficient. And then access and use of services by those who need them. Yes, this is what equity. And then good quality of service, and then financial protection for those who need it. So all of this objective of purchasing, it should be regulated or written by the government, like the commission that oversee and then make a monitor for the process of purchasing. Okay. Now the challenges of purchaser for doing more strategic purchasing. This is how to make primary care and referral care should be more integrated, not fragmented. That is the point, yeah. And then we can see that the way of paying the doctors of the hospital is maybe different here. If here in primary care is capitation, okay, capitation, and then at the hospital it is like PRG type of payment, so like a fee for service. Then the doctors at the primary care, they tend to send patient as soon as possible. So excessive referral, yes, because they don't want to have so much burden here. So they will send the difficult patient to the hospital as soon as possible. Yeah. That is the things that we have to be very, very careful on how the integration are not fragmented. Or if this primary care is owned by a medical doctor, okay, and also the medical doctor also own a hospital. You know what I mean? Is it possible to have like a self-referral from one primary care and then goes to the hospital without like compliance with the indication? So self-referral mistakes, or maybe it is like intention to have more financial incentive of the contract. It is one of the issue that back to the name of seamless or integrated healthcare is not happening. Okay, I will stop here for maybe if you have any questions about, yes, the concept of purchasing and strategic purchasing. Please, is there any comment or maybe question? Are you following my points or not? Please. Any comment? Is it clear or not? Huh? Please. Yes. What?
Would you consider a PPP as a strategic purchasing?
Public-private partnership. Yes, actually, if we look at the partnership, should be like this. Yeah, they should have like a good system that create incentive both public and the private. Yes, okay, and then quality should be there, yes. Okay. So PPP should be done by a good strategic purchasing. Otherwise, PPP is only making inefficiency use of the resources. The budget from the government is contracted to our partner with private organization without any selection criteria, without any monitoring or control of the cost and the quality. So strategic purchasing is one important requirement for PPP. Okay. Okay. Thank you. So, any other questions, please? Yes. If you have any, you can speak in Chinese or in Bahasa Indonesia, and somebody will translate to me in Chinese if you want. No, please. From the Bahasa, from Indonesia. Is it clear? The purchasing and strategic purchasing and how it is related to the primary care and rural care. Okay. Sorry, it's clear, yeah? Okay, so what's my time is 45 minutes left. Okay. Yeah, my time. Okay. So now let's go to case number 1. Yeah. This is about Indonesia finance that yesterday we discussed about this. If you have already your graph in your paper, yeah. So the yellow boxes, these are the resources of ad finance. Okay. This is from the government revenues, tax, non-tax revenue, donors. And then this is from private sources, from premium, philanthropism, and out of pocket. So the premium can be put in the, so this is the BPJS, MOH. So these are the pooling groups, okay? So the money, the financial resources is channels, goes to the pooling here. There are many pools. This is the pool, okay? The big pools and small pools. Yeah. And BPJS in Indonesian health insurance scheme is the single pool. In Thailand, there are 3 pools, yeah, not only 1. In Taiwan, only 1. Yeah. In Taiwan, in US, many pools here. Yeah. Okay. So the purchasing now, so these are the pools. MOH is also pools. BPJS also pools. Yeah. And how to the local government also some pools here. Yeah. And the private insurance. But there are small pools. Yeah. Okay. So now the purchasing activity is happening in this case from BPJS to primary care and hospital care. Yeah. This is in 2017. Yeah. Okay. So we have a mechanism for purchasing and allocating money on behalf of the patients, and we have the purchaser, yeah, and then link with the economy, yeah, the community. Sorry. Oh, sorry. Okay. So this is the purchase agency, and then there's a principal agent relationship that from this box that we described before. So BPJS as a purchaser here, and we have citizens, government, and healthcare providers, public and private. And in 2017, there was a big study on how the purchasing happening in some countries, and one of the country is Indonesia about this kind of arrangement. So the main situations actually, if we have from this 0 to 10 about passive to strategic, the Indonesian system is around here. It's not too strategic, but it's not 0. But yeah, it's about maybe from 0 to 10 is about 4. Yeah. It's not good, but not bad at all. So something like that. Okay, why? Now, this is the thing that we try to understand about the purchaser and government relationship. So now look at this between BPJS, yes, and the government. So we have the unclear role between BPJS and the Ministry of Health or District Office. And this is becoming not too integrated between the government and the social health insurance. Yeah. In the first day, Professor Yo mentioned about this not good integration between social health insurance and MOH, example. And then we have inadequate monitoring and evaluation because data in BPJS cannot be accessed by district and provincial offices and also local government authority. And capacity to monitor the program are low. So actually there's like a separation between local government and the BPJS or the insurance scheme. Yeah. And then also the government has limited capacity for developing new health facilities. So becoming like inequity at the end of the program, especially in remote areas. And then now between purchaser and provider. So the BPJS has inadequate authority, aggregation, or capacity to contract, especially with respect of government providers. So this is like the insurance, the purchaser is, the position is less than the government providers. And then poor contract monitoring mechanism to contract services. And then this is increasing the possibility of moral hazard and fraud. That is the link between purchaser and healthcare providers. And then between purchaser and citizen, the needs, preferences, and priority of citizens in determining service entitlements are not made clear in policy design and implementation. Because if you can see that the citizen of Indonesia is also in Jakarta, the big city like in Hong Kong, but also in Papua in the remote area. And somehow it's so difficult to have like the minimum standard for everybody. Yes. And then the large number of regions where complete needs are not met indicates there's no mechanism to ensure that beneficiaries get access available services, especially in the case of marginalized groups, in the remote areas, or maybe for these disabled persons. So the mental health, they have some problems in accessing the services. And then there's no evidence that citizens can participate in the process of determining health needs and priorities. So it is like a top-down activities, and the citizen is not so much like heard in terms of participation. Yes. And then there's no citizen representation on purchasing power. And then legislation on patient right is limited. So we can see that why the result is still not too active in terms of strategic purchasing. So the capacity to use representation is still weak. Yes. And then in historical analysis, actually between 2013 to 17, the 4 years implementation of the health insurance, actually the concept of purchasing and strategic purchasing is not yet understood. But there is still a lot of room for capacity development in each group of activity actors. That's why the case number 2 and 3 is trying to answer this many requirements. So this is the policy recommendation. 1, empower citizens to participate actively in benefit setting, especially in the case of remote areas, minors, and disabled people. So they are the people that should be protected by social health insurance. This is a very important issue. And then MOH and local governments should invest in facilities and human resources and improving equity in access. So this is the implication of number 1. And then strengthen government stewardship for health equity and establish in an integrated regulatory framework for quality standard, payment requirements, price regulations, monitoring evaluation, and aggregation of providers. So this is the things that Prof. Utarini mentioned this morning for quality, also for price regulations. And then ensure cost-effective contracting. This is very important, including aggregation, negotiation, and management and monitoring of the contract. And this is the point that back to the issue of Indonesia is a big country, and then the remote area actually is very expensive to provide medical treatment there because the cost of transportation, of logistics, human resources, salary is totally different in the remote areas versus the big city. And also in the islands, the small island is also very, very expensive to provide services. And then number 5, we promote and establish a higher quality care through education, okay? And then ensure structural or functional integration of public health programs into purchasing. So this is the point that will be taken into case number 2, that between public health and insurance services, somehow it is fragmented. So this is the thing that we have to make becoming more integrative. And then number 7, this is the thing that is so difficult, is split the premium between the poor people, government subsidized member and salary workers on the one hand, and non-salary members on the other hand, in order to ensure health equity. Until now, it is difficult to make like in Thailand. In Thailand, is still 3 pools, but in Indonesia is single pool. That means the budget for the pool can be used for by the middle and the rich person, because it is one pool. And then enforce purchaser accountability by making relevant data accessible to the public and relevant stakeholders. And now is becoming happening at the moment. And then strengthening quality control in health services, as well as fraud prevention, detection, and prosecution. And this is the way of doing the things to prevent a crime happening in the microsystem of health services. Okay, so from this case study in 2017, then Indonesia moved to make some improvement of the purchasing, especially number 6, ensure structural or functional integration. And this is the things that we'll learn in this meeting. Okay. The case number 2 is strategic purchasing in public health programs, the case of TB. Yeah. So if you look at the background, Indonesia ranks 2nd globally in TB. This is burden. And this is under detection and under reporting, and then high vertical level TB. Okay. That may be because it's better to refer as soon as possible to the hospital, because TB patient is somehow becoming burden for the health center's staff. Okay? And then under detection, under reporting led to increase in TB incidents over the years. Also, treating uncomplicated TB at the level leads to increasing cost to national health insurance. Okay, considering the broader network of primary health care facilities and panel with national health insurance, the government is piloting the strategic health purchasing. So this is a pilot study in strategic purchasing. So in this graph, we can have that the purchaser, there are 2 purchasers actually working on TB. Yeah. One is MOH for the drugs and other logistics, and also the prevention program, the promotion. And purchaser number 2 is BPJS, or National Health Insurance, that finance are working on the capitations and for claims of TB patients at the hospitals. Okay, and also still we have the out of pocket. Now the point is, we have to go to more strategic processing. How the reward system for quality improvement efforts and the rewards, because we are too slow or too weak or not too much energy for TB management at the health centers. So we have to find another way of making this becoming more powerful in terms of the activities. So there are some piloting projects in some areas, and actually there's a payment mechanism, yeah, and then benefit. So we could detail in the TB program, like diagnostic, incentive for completed initial phase, incentive for completed continuing phase, yeah, and then contract and also pilot indicators. Yeah. Okay, and the monitoring is done by monthly troubleshooting at the district level. Okay, and this is the thing that payment mechanism is developed for having a better diagnostic and also treatment. Okay. So this is the result. Increased 108% from 2000 to 20 pilot, like this, and then also become like this, yeah, in Denpasar and in Medan. Okay. So in multiple pilot, the claims submitted are growing over time, mainly coming from public primary healthcare. So the incentive can increase the productivity. Yeah, and the factors that might be affecting results: simplicity of claim submission and maturity of claim application. But we have to make another monitoring because actually, if it is done, it will have like the budget impact is quite high for the national health, no, for Indonesian government, not for the national health insurance. Yeah. Because actually, who will pay for this? It's not by national health insurance, but by the government of Indonesia. So the additional budget not come from the purchaser, but from the government. So you can see that with the purchaser, they are happy with this pilot, but for the government, they have to be very aware that how much the budget impact of the this pilot. Okay. Okay, now we go to the case number 3. I invite Budia to talk about this adding incentive. Yeah, so please. So because she is not doing this kind of pilot thing, not yet finished, but actually it is ongoing project. Yeah, is the microphone? Oh, yeah. So again, these are the things that we try to improve after 2017 monitoring of the safer testing. Okay, yes.
Thank you, Prof. Laksono. And thank you all for still being alive because we are entering the blue hours of the lunch. Hope that, so our case here is to model the incentive for appreciating the primary health, managing diabetic care, especially for National Health Insurance member. So the reason behind this, that we see the number of cases from the members or enrollees of the National Health Insurance is increasing from year to year. So we can see in 2022, so the case is rising into 8 million, more than 8 million cases, but those who are being controlled is minimum, so it's less than 10%, I think. So this is as a challenge, especially for diabetic cases. If we see the prevalence, we have around 11% of the populations that estimated having the diabetic disease. But from the data from the National Health Insurance, our National Health Insurance coverage is nearly more than 95. So it's approaching 96% of the population. So from this point, we can see that those members who are entering or access to healthcare and being diagnosed is also still low. And also the number of cases that are being controlled is very, very low. So that is why we are trying to see can incentives formula stimulate the performance of the provider to at least to manage the diabetic patients so that they can be managed and maintaining the conditions. So from the cost, that nearly 75% of the cost goes to the complications. So this is that we try to see how if the cost in hospital will be shifting to the primary care for providing an incentive at the primary care level. The project run at the 4 provinces, West Sumatra, the capital city, Yogyakarta, and also East Kalimantan, to see from both perspective, the provider perspective and also from the patient perspective. And the aim is to provide recommendations of financial incentive of for primary health care for managing diabetic cases. So we'll see that from the Professor Laksono's presentations previously, that BPJS will be the one who act as payer. So BPJS will allocate some amount of their money in the pool as an incentive, additional incentive to the capitations that are already provided to the primary health care. So we already have the capitations and these incentives. This incentive means if the primary health care is not achieving the target performance, so the capitations will be reduced to 95% of the initial capitations. That's this incentive. So now the BPJS trying to change, or that they will give the incentive as a way to stimulate the performance. And it will give to the primary care directly. And the formula will be, we are trying to post 3 models of incentive. The first one is the flat incentive, and the other is grade. Grading means if they achieve a certain level, they will give a certain percentage, and if they get higher achievement, they will get more incentives. And the other is per patient. So if they are managing 1 patient, so they will give, the BPJS will give a certain amount of money per patient. And these are the indicators. So the indicators is blood sugar level. So number of diabetic patients that have been controlled as the numerator, and the denominator is the total numbers of patients in primary care. If they achieve a minimum target of 5%, then they will get the incentives. So we also see the ability of BPJS on the affordability. If they do this and implement this, what so how big is the resources that will provide to fulfill these incentives? So we are conducting budget impact analysis to estimate amount of incentive received by the primary care based on achievement indicators. So we also trying to calculate potential saving from the diabetic complications due to these types of formulation. Thank you very much. Oh yeah, the last one. So this is the question, the final question. So do you all agree with this formula? Pay performance will change the provider behavior. So provider behaviors will induce the or facilitate to redesign of the services, and at the end it will improve patients' outcome. So how we can link the provider remuneration to quality of care. Thank you very much.
Okay, thank you, Ibu Dia. So this is the example of how the macro policy and financing can influence the micro quality of services through purchasing arrangement. Yeah. So if we purchase without any monitoring or any say like this pay for performance things, then maybe our money will be spent efficiently or unwisely. Okay, is there any question? Yes. Yeah.
Thank you, Prof. Laksono. There are I have question, but it's from participant in Zoom meeting, from Ibu Tati. So she asks, do you think that the single polling in Indonesia has worked well? And then do we need to reform the polling mechanism just like in Thailand, and how to reform that? Thank you.
Yes, I think the single pool has like pro and con, benefit or minuses. Yes, in my observation, I think the Thailand, although the Thailand polling system, there are three, the benefit is different in its pool. But the three pools can safeguard the budget for the pool will be used only for the pool. Yeah. But in the single pool, the budget for the pool can be used by the non-pool. That is the problem, because it is a single pool. Yeah. Okay, this is the things that we have to work on this. Yeah. I think this kind of discussion will be will be maybe more and more discussed. I think next year as well in Thailand, maybe if we have a meeting on the role of private sector in UHC. Yeah. Okay, so we have still 5 minutes to go for discussion. Yeah. Okay, is that right? Okay, yeah. Okay, any other comments, please? Yes.
Thank you. Yeah, so you mentioned a lot of challenges like faced by the health system as a whole, as well as some uncertainties with the pilots that have been rolled out, right? So I think in trying to implement strategic purchasing on a broader scale in Indonesia, what would you say are the kind of immediate next steps? Because there's so much that can be done, right? Like, would it be, for example, trying to like broaden these pilots to the health system as a whole, or to like focus on the supply side? Like, what's the kind of immediate first steps?
Yeah, I think this is the most important issue, that the pilot is come from academic environment, okay? Academic people, that the innovation should be piloted, okay? But no, when the pilot already provide some result, good result, then we have to look at this is the pilot and should be scaling up to the whole community. This is the tricky things. Many of the pilot that provide a good result, it's difficult to be executed at the national level, because one of the biggest issue is about the budget impact. Budia mentioned about this for the pay for performance. So how much the budget impact if this innovative will be scaling up to the national level? And this is becoming a political question, because we have to fight in the not only in the MOH but also in the parliament for adding more budget to make the purchasing is becoming better. Yeah. So how much does it cost for innovative way of making the purchasing is becoming better? So are you following my points? Yeah, it's not easy. Yeah. But we have to do something for this issue. Okay. Yes. Yeah.
I think I'm not answering the specific question, but I'm just answering the question in terms of how can one proceed? Because tomorrow we could talk about the implementation, monitoring, evaluation, and it's quite important, because when you look at implementation things, you look at scalability. So as you said, the pilots. What do you learn from the pilots? How do you evaluate it? So the question that asked is very important. So when you design an intervention, you need to really look at what you're supposed to achieve, your intervention outcomes, and the process. That's exactly the problem. The process of the process, and that's why we have this implementation tomorrow we talk about it. So you'd be doing that if you have a very good program. You already start to look at the implementation process and the intervention, and then you evaluate it, and then that could help you then scale up. So the scaling up, the scalability is one component of the things that we do in implementation sciences. So the question you asked is very, very relevant to what we're going to talk about tomorrow. Okay, sorry, I didn't want to ask it.
But for Singapore, it's much easier, is that right? Because Singapore is small. Yeah. But you can imagine that Indonesia 275 million in a big country, and the implementation result or the pilot study in say 4 or 5 provinces. We have 38 provinces, and then it's trying to be put scale up to the national level. It is so difficult, but we have to do. Yeah. Okay.
Yes, thank you. Professor, my question is, on the diagram of BPJS, it was mentioned that BPJS is being the purchaser. My question is, has Indonesia become a strategic purchaser? Because there are issues about local government purchase products for the programs, but the product is not suitable for the programs at the puskesmas. So it has caused some troubles in our healthcare system. What do you think, Professor?
Yes, that's right. Because actually, when we look at the triangle of purchaser, the government, citizens, and providers, citizens' needs and demands should be important factor in such purchasing. And this is happening because actually, when we look at the regulation, we have the medical benefits set at the national level. Okay, regardless whether in one district there is say cancer surgeon. Okay, but it is okay. The surgery can be used for cancer treatment. Okay, but if one district they don't have hospital or cancer surgeon, that means there will be no operation there. Okay, are you following my point? It is difficult because we have say 518 districts. Okay, and the cancer surgeon is only maybe 40 districts, yeah, or city, yeah. So the rest still empty. Yeah. That is the biggest problem of Indonesia for providing the whole service for everybody in the same condition. But because the regulation is set at the top level, that every members of Indonesian's health insurance scheme, they have the right to have cancer surgery. But if there is no cancer surgeon in their district, they have to pay by their own the flight to, say, the capital of Jakarta, for example, and it is costly. For the poor, they cannot afford. Okay, so this is the problem. The biggest problem of Indonesian health insurance is how to make all citizens becoming accessible for all benefit of the health insurance. It's different with Singapore. I think Singapore, everybody is how many minutes to go to hospital? 20 minutes. So you can see 20 minutes. We can have 3 days to go to hospital. They have to go to by boat using because the long river, and then they have to go fly. Yeah, so you can imagine it's totally different with Singapore. Okay, the time is up, no? Okay, thank you very much for your attention. See you again tomorrow with Pak Mubasir for contracting. Yeah, thank you very much.
So we come to the next section, which is about the country experience in the purchasing, organization, professional, clinical mechanism. We have Professor Chen first, please.
Okay. Yeah, good afternoon. And I appreciate and join this and that's the seminar. So I will talk about the China's and the situation and the purchasing and organization mechanism for integrated seamless healthcare. But I think and my talk and mainly focus on maybe it's not integrated in the seamless healthcare, just purchasing and organization mechanism in China. You see what? I have the four parts, and the first is the China's country profile, and that's the healthcare, and that's the situation. And the second, this is because the page down. Yeah, it doesn't work. This is okay. Mouse is. This one. Four parts, and just the first country profile, second organization and the mechanism and the service delivery, and the third is mainly is health insurance, and that's the situation, and the fourth is just expectation in future. Okay, China's country profile. So that's the China, the basic and the situation. I think that's a population that is big, and 1.4 billion population, but also such a big country and with so populous population, but also the aging is also significant. So that's, I think, is a lot of challenging for the China healthcare. And just in the last 20 years, and China is more and more urbanization. So that's right now, and the urban resident already 0.9 billion, and occupy 64%, and the rural area is just 0.5. If back to the 30 or 40 years ago, actually, and China and more people in the rural area, and then less than the population in the urban. And the population, that's the pattern, and right now, and you can look at the three number in the year of 2010 and the 2015 and the 2020, and you can look at the aging population over 65 already 191 million population. So occupy 13 and 0.5 and percentage. So you can look at that's the aging trend in the last decade. So that's the population. So this slide shows the total GDP growing, and in the yellow bar, and that's the green bar is the total health expenditure. So we can look at the beginning of this, and that's the figure is 2009, and 5% of the total GDP invested in that's the health sector, and to the 2019, and that's the GDP. That's health, total health expenditure share GDP is 6.6%, and so that's, I think, and it's also growing and for the health sector investment. So this is just recent years, and the total health expenditure in 2020 is 7,000 billion RMB, and so equal to how much in the US dollar share of GDP already, and reaching 7%. So that's, I think, and much, and that's increasing in recent years. Per capita health expenditure is 5,000 RMB and equal to 700 US dollar. In this, the total health expenditure, that's the government health expenditure, 30%. And the social health insurance expenditure is 42%. And out-of-pocket health expenditure is 28%. Government health expenditure, including those kind of like government and the investment in healthcare and the facility and the development and public health and that expenditure, those kind of things, all and belongs to government health expenditure. Social health center, that's the expenditure, mainly is the social medical insurance paid by the employer and the employee. So that's the social health expenditure. Out-of-pocket means, and yeah, that's when we get services, we also should pay for something. So that's out-of-pocket. But also some people just go to the drugstore and take medication, but that's out-of-pocket. So that's the that's the composed of total health expenditure, and the red bar, that's the government health expenditure, and the green bar, that's the social health expenditure, and the blue bar, that's the out-of-pocket. The blue line, that's actually is the share of GDP, and so that's just look at the other side, that's the Y and the axis, and so right now is already 7% of total. Yeah, that's the total, that's the GDP. So that's just the expenditure, and look at the health indicator. I think and China already achieved a lot, and in the last whatever decade or last 3 or 4 decades. So right now, I think our life expectancy is almost close to 78 years old, and the infant mortality is 5 per 1,000, and the maternal mortality is 16 per 10,000. So that's under all of those kind of figures show that maternal mortality and that's neonatal and the mortality and the infant mortality and the under 5 years old, that's mortality. So all those figures have 3 lines. Okay, that's so that's the different I think that's the in the middle, that's actually the total countries and the average. And so that's the blue line that actually is urban area, I think is better. And that's the yellow line actually is rural. So you can look at and the mortality rate right now, I think urban and rural almost the same. But the other, you can look at, I think the urban, that health indicator is much better than the rural area. So that's just the that's main health indicator. If you look at the disease burden, so that's based on the IHVs and the data, you can look at that and the structure. I think both occupy the non-communicable diseases. So those and the pattern actually is close to the developed country, and that that's yellow and green, and for those kind of communicable diseases and injury, I think and actually is just quite small. So that's, I think, in China, that's disease burden mainly is occupied non-communicable diseases. But the pandemic also remind us, I think, communicable disease also can give a greater stress to the health system. Yesterday, we also talk about our groups and talk about China's hospital and the primary health care, and that's the facility and the situation. So I will show you some and the figure, and that's the hospital number or primary health care number and their services. So this slide shows that growth in the total number of hospital and classified by the public, non-profit and the profit, and that's different, and the hospitals, the number, and they're just changing from the year of 2005 to 2021. So that blue bar, that's public, and the red bar, that's a non-profit, private, and the hospital, and the green bar, that's the for-profit hospital. So that's in the first year we show here is 2005, and you can see how many hospital. I think that's the public hospital dominant and occupy all those kind of things. And you can look at the percentage, 83% of total hospital. And then through the years and the changing, we can look at 2021, and you can look at and the public hospital right now is much less than the private hospital. Mainly it's a for-profit and private hospital. So here is the 32% of public hospital, 24 and for non-profit, and 44% that's for the private hospital. So look at this and the figure, you will say, oh, in China, I think the private hospital already over public hospital, but actually is not the truth. And then we will show you their services. Public hospitals contribute how much and services, and also for-profit and hospital contribute how much services. So that's just hospital and their primary health care facility. And you can look at in the year of 2005, actually none, and that's private and the primary health settings, and in the year of 2005. And their 2021, and I think basically is still and they're dominated by the public primary health care facility. Totally is 52%. And then the for-profit and non-profit totally is 48%. I think that's the for-profit is 32% and the non-profit is 16%. So that's for the primary health care facility. And in the urban area, we call community health center. In the rural area, we call township hospital, and also some other and their facility. This slide shows the regional distribution of a private hospital in the year of 2021. And that's the totally is the 24,000, and they can have different type and general hospital. And I think about more than 50%. And also we have a lot of TCM, traditional Chinese medicine hospital, and the 2,300. And also the combination of those kind of things is 600. Sanity is just like in the Tibet or Mongolia, they have some like traditional, that's the local sanity and facility, not too much, and those kind of hospital. Specialty, you can look at, just we mentioned yesterday, about 8,000, that's specialty care, for example, for eyes, for some like OBGY, and also the dental care, those kind of specialty hospitals occupy a lot. And the nursing is actually is also not too much. And that's the different region, I think, and the percentage almost and just normally and distributed in the east, middle, and west part. But some is just a very special number for this kind of ethnicity and hospital. I think most in the west part, and the nursing and the facility mainly in the east part. So that's the different like private hospital regional distribution. Okay, the beds and by the different kind of hospital ownership. We also look at the first year and the 2005, and the 95% of beds actually all in the public hospital. Just 5 or 6% and scattered in the for-profit and non-profit hospital. Then and we see the year of 2021, and still and the public hospital have 70% of beds, and the private hospital, we already mentioned the number of hospitals is big, but the bed is not too much. So total that's beds and just 30% of total beds. So that's just the situation. So private hospital, you count on the number very big. If you count and in perspective of beds, and they just not too much and 30%. So then we'll show you if services amount, how the public and private their distribution. So that's the outpatient that's visited by the different kind of hospital ownership. And in the first year here, we show the 2005, 95% that's actually is a public hospital provided. And though the other, whatever nonprofit or for-profit, totally is 5, that outpatient and the service list, that's the structure. Look at 2021, and so public hospital, the number of hospitals, although is small and 40%, but their services, outpatient occupy 85%, and the other and just occupy the 16%. So that's maybe they are mainly private provided VIP services, and so that's service number is not so big. So that's the outpatient visits and the distribution. Look at the inpatient and the admission. So almost the same in the beginning as the 95 or 96% by the public hospital that's providing inpatient services. Here, that's in the year of 2021, and the public hospital contributing 82%, and the other and the private and the non-profit, and that's the occupy and 16, 18% of total admission. So I think that's just the basic and the situation. So public hospital and actually is the backbone of China's healthcare system. And the private hospital, they also contribute some those kind of services and just meeting the population, maybe the diverse and the healthcare needs, and just response to the population's demands. Okay, so that's the first part is just a basic and the number. And the second part is the organization mechanism and the services delivery. So in China's medical or healthcare services, I think is provided by the two different kind of things. So the tertiary and the secondary, that's the medical services, and we call those kind of hospital providing such kind of services. Primary medical services mainly and just from primary healthcare facility, township or community health center or village doctor, and they provide it. So what's their services function? So tertiary and the secondary hospital, they provide specialty medical care, emergency care with more advanced medical supply. General preferred by patient as better qualified doctor. So in China, we don't have the gatekeeper mechanism. So patient can go to whatever they want to go. So most of people, they want to go to the hospital and maybe to Beijing or Shanghai or Guangzhou. And right now in the rural area, so they also want to go to the county hospital to get treated. So that's, I think, is they prefer to go to the hospital. And at the provincial, city, and the county level, they all have different kind of a hospital. And the urban is, we have secondary and tertiary care, and the rural is mainly is secondary and care. And if we cannot control in the rural area, so referral to the urban. But we don't have the strict and mandatory referral system. And actually, the doctor can go to whatever they want. And the other thing I think in China, those kind of tertiary hospitals, their efficiency is quite high. If I have some sick and I go to the public hospital, I think I can get and see the doctor today. Not we should have the appointment and a couple of days or 1 week appointment. No, right now, and you can get and see the doctor, maybe just a few hours waiting. So that's very, very quick. And but if you want to see the expert, maybe you need some appointment and maybe a couple of days waiting. But if you see just normal and the doctor and think you can see the doctor today. So that's first. Primary, I think, and that's our system, just a combination of the medical care and also public health. And tertiary hospitals, they have some public health and function. For example, emergency, those kind of services, and I think they have some public health and functions. But those kind of like a vaccination or some prevention or disease management actually is provided primary health care facility. So those facility have the medical and also public health services together. And the rural, we call the township healthcare center, and also the village and clinics, and the urban mainly is a community health center. But the community health center also has some posts in the community. Yeah, just let the population is easily accessed to. And their charging is also different. And the hospital may be charging a little bit more, but primary health care may be charging a little bit less. And that's the differences. But it's not too much, and the differences, and that's from the price and the perspective. In China, medical service delivery, and I think, and the resource distribution, and we hope we will set up such kind of triangle. I think the basic healthcare, public health is the fundamental, and that's the solid foundation. And the top, and then in the specialty, and yeah, just some very difficult cases and treated by the tertiary care. But China's health resources actually is inverted triangle. So actually is strong in the tertiary hospital, and that primary care and facility is quite less. So here, just say that's the Winnie Yap, and that's her and the publication, and the say reverse health resources at different levels of hospital, and about 6% goes to tertiary hospital. But bottom, the primary health care, just 18% of resources. So China actually is a reverse triangle of such kind of system. So the policy and their goal try to just make it and back to the normal, and just primary health care should be the foundation. So that's our reform would like to go. So this slide shows that's the different levels that facilities, their outpatient and visits, and also inpatient that services. So that different color, and that's the hospital is blue, primary health care, that's the green, and that's the other one is the total. So then the hospital occupy how much, and the outpatient services, the primary health care, and that's occupy how much percentage. So I don't want to go through those absolutely number. We can look at that percentage. So in the year of 2005, I think, and that hospital that's occupy, that's the 35%. And that primary health center and occupy 65. So at that time, I think hospital is small part of services. And after those years and changing, you can look at hospital, the number is just increasing. So that's why I say, so in China, and we have a lot of policy, actually is supporting primary health setting, but in fact, the effects is just the hospital is growing and growing. So that's the situation. More people want to go to the hospital to see doctor. So they think about hospital doctor, the quality is better. So that's, I think, is also not the policymaker would like to see. Actually, we want to say, okay, the hospital is still stable, or a little bit and less, and primary health is more and more, and they're big number. But right now, actually, they just close. So that's the outpatient services. But I think inpatient services is also the same. So that's hospital, that's the that percentage is in red, and the primary health care, that percentage is the blue. You can look, and the hospital from the year of 2005 is 75%. Right now is 85%. So we always think in China, hospital more and more powerful, more and more to be a giant. So primary health, put them together, but still is in a weak and status. So that's the situation. So you can look at the community health center, primary care, 25%, and to the 15%. So that's, I think, in the situation. So in China, that's the primary health care facility, we still need a lot of policies supporting them and survive, and also have more functional and contributing, and those universal health coverage and provide and equitable and also quality and efficiency healthcare. Maybe I can analyze some why and in China like this. So from governance structure, I think in China basically is public and private mixed system. But in China, I think that public hospital, that term may be a little different as in Hong Kong or in Indonesia, or in India or other countries. So I think in China, those public hospitals, they have a lot of autonomy. They have a very freedom, those kind of how to use deficit and try to develop themselves. And those kind of autonomy and give the public hospital a lot of strong incentive to provide more services, also charging more, and then they get, I think, and those benefit or deficit and back to the hospital themselves or back to the providers and the pocket. So I think that's the basic. So in China, and I think the public hospital lack of government support, and that government subsidy is very small. I would like to ask you, can you and guess how much percentage of government subsidy share of that's total, that's income or total expenditure, that's the public hospital? Do you know how much and the government subsidize that percentage of total, that's income or total expenditure? In Hong Kong, how much? 97. You know, and the mainland, how much? Okay. I think about 10% in average. That's government subsidy. Oh, yeah, just the share of the total expenditure. So 90% that's actually not Hong Kong. That's from the government. 90% from the services, but also including the insurance, including out of pocket. So that is totally also reversed. So I think, and we say the public hospitals actually have autonomy, but the community health center township, this the government and give the total budget to them. So they are the budget. They have the budget institute, but the hospital is the autonomy. So I think that's maybe, and that's the main reason. So why the China's public hospital so growing so fast? Because they don't have sufficient government and the support, and they just survive in the market, and they try to and just survive. So that's, I think, because timing, and I don't want to go through. And here also have the public health and delivery system, and we have different kinds. The other thing I think is also very unique, and China's public health system is also vertical from the central government and to the just the bottom. So we have the CDC, we have the maternal and child health, and also mental health, and also health supervision, and just look at those hospitals, their doctor have the license or those kind of things. And also blood collection and the supply, and also health education. So all those kind of things is just a vertical system. So I think it's also very good. And but the problem is how to just integration of public health function with our hospital, with our primary health care facility. Oh, their services, public health services, medical, and those kind of things, because I just have 5 minutes, and so I go through those kind of things. So a lot of non-communicable diseases also have a process. And okay, so I still want to talk about health insurance and the purchasing mechanism, and that's the milestone. And so in China, I think that's the medical insurance. And right now, I think in China is mainly two kind of schemes. So one is employee basic medical insurance. So that's, yes, 344 million and RMB, and that's in 2020. And the other is urban and rural resident. So they without any employer. So they just put them together, and that's the resident and the medical insurance. That's including government subsidized and also the out-of-pocket from family or from individual. And that's the basic two medical insurance scheme. And then we also have the other supplementary, those kind of medical insurance for some catastrophic and diseases and for the commercial, and also some critical illness and also charity. But the bottom line that actually safety net is the medical assistant, like a medical aid and the system for the very poor population. So that's just the multi-tier insurance schemes in China. I won't go through those kind of things. And so that's the cover population. Here, just say 95%, I think almost close to 99. Okay, that's the, I think the other thing is universal health coverage. And so right now, 99% already covered. And what kind of service covered by the medical insurance and how much percentage and paid by the medical insurance. So that's the universal health coverage. I think for us, it's just the services coverage and also the cost coverage. So that's, I think, the UHC for China. Here, I just the case about how to use HTA and just assist the policy making to just update the national reimbursement drug list. And we use cost effectiveness and review and just discuss with the pharmaceutical manufacturer and cutting the price and try to just save money. And for the sickness fund, actually is also kind of a strategy for the strategic and purchasing and from medical insurance. So I just want to go through those details. And the other thing I think we also talk about inpatient services. And in China, we try to use DRG and try to just control the cost, but also try to just ensure the quality. And but the challenge is the DRG and also just the deterioration about the quality of care. And so that's the challenge. And the other thing in China and also medical insurance use the global budget and plus DRG and for the inpatient services and for the outpatient services, and they still use those kind of people services. And so that's sometimes, and that's the insurance and that's the sickness fund is also challenging those kind of deficits. Okay. So, but also the hospice, and I would like to say that the cases and whether we can do more PPP and for the hospice and because of timing and just go through those things. Okay, finally, it's just we have achieved a lot, but I don't want to go through, but we still have a lot of challenging. So that's, I think challenging maybe I just public and private, how to just have the private have more function for the China healthcare system, and how to integrate the hospital and primary healthcare, and also how to integration or have a better function and the clinical and preventive, and also insurance and provider integration. But I think in China maybe we challenging how to set the right incentive, including the kind of how to control, but also give the good and incentive for the right and the behavior. So how to reimbursement for integrated seamless healthcare and still challenging. Okay, so the summary and that's I think, and just the cases for the that's our participant. I think about and how to set up the restructure China healthcare system, and they're just keeping those kind of achievement, but also solve those kind of challenging. And I think this and the seminar is also helpful for me and also for us, and to give some recommendation to China healthcare system restructure. Okay, so that's one. Okay, so that's my part.
We come to another experience sharing from Malaysia, Professor Wan.
Okay, hello and a very good afternoon. I am very honored to be here. Thank you for the invitation to Prof. Ike and also Prof. Laksono. And I have seen the esteemed talks by our colleagues and our teachers and by our friends here. I'm just going to finish off some of the topics on clinical mechanisms. So some of them might be a bit redundant from what you have, and I'll try to speed it up, but some I'll stick more on it because this would be something which is relevant to other countries, including Malaysia as well. So I come from Malaysia, which is a so-called an upper middle income country. I call this so-called because, you know, after the COVID, a lot of financial difficulties and we have problems financing our healthcare as well in Malaysia. Our GDP per capita is not that high. We are in Asian, we are considered less than Indonesia for 2023. Of course, if you look at Repro region, the highest would be China, and of course, our income is not that high. The healthcare expenditure increasing more than the GDP increase in Malaysia. So the percentage of GDP being used to finance healthcare is less than 5%, as advocated by WHO. So it's usually around 2-3% plus and so forth. So we have difficulty in financing our healthcare. We have been colonized by British for 156 years, meaning that we use the national health system by UK. So most of these are tax-based financing. Most of these are subsidized by the government, and we cannot sustain this on the long run. That's some of the opening areas which I want to touch on. So it's very much a public expenditure, but there are some areas where the public health system is actually very rampant in Malaysia. Most of the income that comes from the private actually goes back to the government. So this is private healthcare. The government is totally into private healthcare. They really love private healthcare in Malaysia because that would actually finance not only the high income groups, but also the tax and so forth will actually be pumped back into the government. So this does not occur in our public system. So as introduction, I would say that most of the issues in many healthcare is because of the wastage and leakages and the issue of increasing healthcare costs, including drug inflation costs and so forth, oncology treatments and so forth. This is very expensive, including in many countries in Malaysia as well. Ironically, we are supposed to be following UK, meaning we have a universal health coverage, UHC. And when that happens, meaning that a lot of the community will actually receive sort of free or subsidized healthcare from the government, but this does not happen all the time. Most of the patients would go into the public system, yes, but our beds are not enough. Even though the beds are in the public system, we don't have enough specialists because our specialists would actually go into the private system. This is the issue with brain drain. Most of them would actually go for their specialties and then they will leave. So the intention to leave, resignation is about 6%, but the intention to leave is about 46%, meaning that most of them would actually want to leave the public system. So these are some of the reasons, which includes the inappropriate funding, not enough healthcare resource, and so forth. And including in many countries, and we have seen this, you know, the more uninsured or you don't have money, basically you might forego healthcare services. And even though that US would actually use the highest percentage of GDP to health, it's not one of the best outcomes. If you compare this with other countries that is socially financed in insurance and so forth. So in some of our literatures as well, so in Asian countries, these are some of the Asian countries, and some of our friends are here from Indonesia, Malaysia, Philippines, Vietnam, and so forth. Our level of government spending on health is actually not that high compared with other countries like OECD countries, US, and so forth. So, but it is lower than the global average. OECD countries, of course, spends more. And what happens is that we also have a lot of medication error, with a lot of issues with medication errors and so forth in Asian, including in Malaysia as well. So I think I'm not going to go into too detail of this. You've had multiple lectures on health purchasing and what is strategic purchasing, and why do we need strategic purchasing, how to buy, who, and so forth and so forth, which is part of the purchasing. And this is not procurement. Purchasing is part of procurement, but when we talk about strategic purchasing, it's more of how purchasers actually purchase or obtain healthcare services to the population, and how are you going to segregate that, who is the population that you want to serve, and so on. So in universal health coverage, the importance is that primary care actually help to catapult universal health coverage, not only in public health, but also primary care. So most of the countries that has universal health coverage, by right, the dimension would be they are able to finance the services. So people will not forego services. You have people who are able to obtain services even though they might not have enough money to actually purchase healthcare services. And these are some of the importance of universal health coverage and primary care. I think I'm not going to go into details in this. I think you've seen that a lot as well today. And it must reach all levels. So even though that we use strategic purchasing, all of this must go into our, some countries have probably be more in place into universal health coverage. Some countries have not gone into universal health coverage into more detail, or they have not arrived into universal health coverage. And I think that by WHO advocate, you or countries are highly encouraged to sort of go into universal health coverage, because this will protect your population. So each country would be in different stages of reaching this. So if you look at some of the examples, distribution of purchasing functions in different systems, example in Malaysia, here where I come from, so I'm situated in between Thailand, which is on top of me, and at the bottom would be Singapore. And my neighbors would be Indonesia and also Borneo, which is Sabah Sarawak, and also Indonesia, Kalimantan. So Malaysia, we have provider payment development. Most of this comes from, like I mentioned, subsidies. So it comes from Ministry of Health. At the moment, it is single payer. We don't have a social health insurance yet. We are supposed to go into national health insurance, but we don't really know when we will arrive there. It has been mooted for the past 30 years. And the payment is basically by the Ministry of Health again. So the rate is actually very, very low. And there's no provider contracting at the moment, because it's a single payer by the government. And the quality monitoring are also done by a single payer sort of, which is the Ministry of Health. And we want to adhere as much as possible or to progress towards our UHC, our universal health coverage. And this is what has been mentioned, where to buy, from whom, how to buy, and so forth. And you see that these are some of the ideas or details under purchasing, strategic purchasing in relation to providers, to citizens served, and also to by the government to promote strategic purchasing. So what should be in place? And universal health coverage in Malaysia, these are some of the criteria of universal health coverage. Right, and by right, this is where we mean that the people will not actually face financial hardship. So in Malaysia, we always make a joke, why universal health coverage, but our out-of-pocket payment is actually increasing year by year. So if you have universal health coverage by right, your payment, out-of-pocket payment, will not be very high, because mostly everything will be covered. But ironically, our out-of-pocket payment is actually increasing year by year. So the latest was about 1,400 per person per year. So meaning that the person or the population will actually enlist private GPs or payment out of pocket for certain drugs and so forth. So why this is happening? And you can see that most of the government clinics would actually close at around 5. So after 5, they will actually go to private and things like that. And some of them more financially off would actually obtain healthcare from the private GPs and so forth. So GPs is very, very important aspect. They are totally private and they hold a big percentage of health clinics in Malaysia. So we have about on perspective, we have about 1,000 public clinic in the whole of Malaysia. 1,000. We have about, I think, about 5,000 private GPs in Malaysia as well. And we have about 150 public hospitals, and we have about 300 private hospitals in Malaysia, meaning that the number of private hospitals actually is double compared with the public. But the number of beds we have higher in the public hospital. So meaning that people get admitted in the public But when they want out-of-pocket payment, or basically when they went for outpatient department, they will go for the GP treatment. All right, so yeah, so it's supposed to reach marginalized groups and so on. And these are the direct benefits, which I'm not going to go into detail as well. I think you've had some experience in other countries as well, and some explanation where supposedly because of this equity, the universal health coverage, you will have direct benefits, includes your improved life expectancy, improved quality of life, you have a reduced prevalence of diseases, fewer hospital stays, and so on and so forth and so on. So incorporating integrated healthcare into universal health coverage is very important, right? So integrated health care is defined by APA as such, referred to as interprofessional healthcare. So it can be a multidisciplinary team working together. Example here would be example for cancer care, working together, integrated healthcare between nursing, social work, staff, and so forth, until you build up a system where it is universal health coverage and the purchaser are able to purchase services for this population. Now, in paper, it looks very nice, but sometimes it's not practical, but it's also very difficult to obtain. So purchasing in integrated healthcare, some of the literature would actually show that it is good to have policies. So this is where the problems of health policy comes in place. And we talk about health policy, it goes back into the governance, how the government put up with health policies and so forth, but also value-based payment or value-based reimbursement. In some countries where you have insurance, this is where your value-based reimbursement will come in. But in other countries, basically, you look at some value-based payments model. Example for Malaysia, we look at a lot of the health technology assessment of drugs, of vaccines, of any modalities that we want to obtain, so that the whatever delivery of treatment or vaccines or drugs that we have will be based on a very competent value-based evaluations. So where the members are empowered to apply their skills and training, role of team members must be clearly defined and communications channels are being established. So value-based payment models, so I'll touch a bit on that later. So some of the ways that they actually advocate for strategic purchasing to address universal health coverage, but still maintaining an integrated healthcare includes, there's three. Number one is to establish an internal office for strategic purchasing. From some of the slides presentation by other colleagues, I see that some of the countries have already a strategic purchasing office or central unit that you actually purchase your service, whatever. Yeah, but in let's say for Malaysia, which is very tax-based, single payer, it is single, basically the Ministry of Health, which is the purchaser and also the buyer, basically there's no split. So they are actually the one purchasing it. So it will be good to have establish an internal office for strategic purchasing. These are the criteria by right when you have this sort of internal office: good governance, fair competition, and this depends so much on the policy and the guidelines that you have in place, centralized procurement and so forth. And this would be by right, be cost saving, improve health outcomes, improve your equity and financial risk protections and so forth. Some examples, again from literatures, is that in England, most healthcare goods, including drugs, equipments, protective equipments, are bulk purchase, so mass purchase, reduce the amount of cost per unit, and distributed to providers, which is about 5 million orders per year. In Norway, also, this is the central purchasing unit with the drug procurement corporations, blah, 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 makes the mass purchase procurement of drug, which is worth about $94 million. And again, this reduced the cost price that they are able to purchase for mass purchases, because it's done centrally. Again, for Malaysia, it's the same thing. So we have it under the Ministry of Health. They purchase the whole bulk vaccines, drugs, everything for the whole country, for public sector. For private, they purchase on their own. So we don't have that, except for during COVID. So during COVID, there was actually a change of events where the mass purchasing was actually done by the Ministry of Health, even for the private. So that was considered an emergency area. So number two is that the most important and other important things would be to use health economics evidence. So this is, I think, very important. I think most of the country will have their health technology assessment unit. In Thailand, we have their high type, we have international HTA and so forth. And Malaysia as well, we are not left behind. We do follow our colleagues as well. So we are trying, there is already a HTA assessment unit being set up. Why I talk about this, because this is part of the clinical mechanisms, how to make sure that you maintain the quality, but also ensure that you are able to provide services at a very cost-effective price, sort of price for the population. So again, when you talk about economic evidence, most of this will depends on your evidence-informed decision-making. So it's not just plucking data assumptions from the sky. These are evidence-based medical unit and data and so forth. And your purchasing decision will incorporate all this evidence. And the health economics, either you do a cost effectiveness analysis, you do a cost benefit analysis, you do a budget impact after that and so forth, which drug, which vaccine that you're going to choose and so forth will actually influence how you purchase the goods and the services. And this will be later on. I mean, for Malaysia, it will be later on, but in countries that has incorporated your insurance, this will be used in your health benefit packages. So the health economic evidence will incorporate some sort of HTA, health technology assessment. And I'm sure a lot of countries have already this in place. So you can actually purchase things or purchase services which are cost effective, but you don't want it to be too low until it compromises the quality. We don't want it to be too high until the end that you're not able to pay for it, or you're able to only pay for a few. And you have to get the settings of the price, just right so that you're able to pay that. And so this is another example from Center for Global Development in Thailand. A price negotiation working group was negotiated for the price of intraocular cataract and so forth, saving around 258 million. So the third important things when you implement strategic purchasing, and try to cover that as some of part of the clinical mechanism, would include electronic health records and some sort of digitalizations. So it can be digitalizations of inventory management in these countries. It has been done in India, some other countries as well, including in Malaysia, Philippines, and so forth. Again, this is from literatures. And so I'll expand more on that, on the electronic health records as well. So these are some of the issues, again, from literatures. And when you talk about clinical mechanisms, some of the things in place already, example, when I mentioned the HTA just now. So this is an example from our web, so-called newsletter or website, that this is done by the Ministry of Health. We in the universities or in academics and some of the private universities are also members in MAHTAS, so-called the Malaysian HTA. So we are members of that. So we provide advice on scientific documents and so forth, some of the methodologies and so forth. So these are things that they come up with, newsletters, and what is the recent development and so forth. So you can see here, example, the recent one that has been managed is that the CPG management of E-Bali, because the issue of smoking and also vaping in Malaysia was very high. So they have come up with the CPG for E-Bali in Malaysia themselves. And the recent dengue vaccine, some of the, I know that Philippines has their dengue vaccine evaluated as well on a cost effectiveness analysis a few years. So some other pharmaceutical agencies as usual will push more vaccines into Malaysia as well, and Takeda has done that. So these are some of the assessment that they have done for HTA Malaysia have done for Malaysia. So this is Takeda. These are examples in the website that they are trying to, advocate to everybody to increase awareness among the GPs. And so these are downloadable and it's free for public to actually look at. So you talk about the COVID vaccine, your pneumococcal vaccination for the elderly, ivermectin, there was a big hoo-ha about the ivermectin at the point in time. So this was also evaluated clinical mechanism. So they look at some of the CPGs. So they look at CPG, clinical practice guidelines. So of course, the component by clinical practice guidelines, these are some of the literatures that it must be transparent, it must manage conflict of interest. So Academy of Medicine Malaysia examples, they have come up with a long list. Actually, this is a long list, this is not exhaustive, just taking a few snapshots of that. So they have come with a long list of clinical practice guidelines that can be implemented either clinically in the hospitals, but also in the primary care. This is to supplement the universal health coverage just now. So example for acne vulgaris, so this is definitely not clinical based. I mean, you don't have to be admitted for acne vulgaris unless it's very severe, but most of these will be in primary care as well, atopic eczema, psoriasis, but they are also treatment for certain extensive clinical management in the wards as well. So clinical practice guidelines are some of the clinical mechanisms to help in your UHC as well. So these are some of the CPGs being developed locally, Malaysian experience, so management of breast cancer. Of course, you have to update this. So you have your 3rd edition, 2nd edition, you might have a 4th and so on. Dengue and some of them that can be used in primary care as well, heart disease in pregnancy and so forth. So these are some of the examples. Some of the components in the CPGs will include things like compositions, right? Who are the panelists, who are the team members and so forth, what are the scopes, the methods, the evidence, and so forth and so forth. So we are supposed to adhere to these components when we actually make up the CPGs. So other quality care improvements would include clinical pathways, which is beyond the scope. So I did not actually elaborate on the different, how does it differentiate between CPGs, clinical pathways and clinical protocols and so forth. But other quality care improvement, which is done by HTA Malaysia, includes such as this, clinical pathways, clinical protocols and CPGs. And all of these are supposed to increase efficiency, reduce your variations in patients management. In the end, you reduce your cost, and in the end, you have a better patient's outcome. So this is the end result. Clinical pathways, this is one example. Probably this is not Malaysian, but I'll just show you how it's relatively been done. So this is used in our case mix system as well. I think this is also used in INA CBG Indonesia, right? So developed by interprofessional teams in clinical management, less used in primary care, but you still can actually modify or update it to suit your primary care use. Assist in clinical management of patient care, including discharge of the patients and what happens after discharge. So clinical pathways are also used as well. And also examples would be our peri-operative mortality reviews, POMR, and also audits, which is part of that. So these are examples of clinical mechanisms. These are, sorry, it's in Bahasa, another one is in English. Consists of medical audits in cases of patient's death which occurred in the OT, surgery, and so forth. And it's defined by any death, blah, 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 and so forth. So this is not important. This is just examples of how clinical mechanism actually help us in achieving our UHC as well. So it's a form of clinical audit. You can actually go to this website. You can look at some of the examples of our POMR. And this is the forms that has to be filled when actual death actually occurs. So these are some of the forms that they can do online. And of course, some of the audits results showing that, the reporting rate has actually increased, which is good, meaning that more people report about death and why this happened, because this will actually reduce your medical errors and improve your patient's efficiency as well. And also this is the rate of the denominator, the cases, and also the POMR, which is very small, but also the percentage in that. So you can see that it's actually increasing, but for me, this is very good because more people are aware they're able to report and not scared to report. So these are very important. So other things that is part of the clinical mechanism. So I've talked about CPGs, I've talked about clinical audits. The third would be, some of the examples would be patient safety goals, or the Malaysian, in our case would be the Malaysian patient safety goals. So these are some of the brochures of a private hospital in Malaysia, how they actually advocate on international patient safety goals. So then the patient, when comes into, let's say, Mahkota Melaka, which is very near to our sea, a lot of people actually come for medical tourism there. So they are very, they become impressed if they look at the brochure and say that, oh, everybody is talking about patient safety. I feel safer already, that sort of thing. So we have this for nursing as well, right? So these are some of the examples that to improve clinical communications. We have 13 Malaysian patient safety goals. Again, this website is there. You can have a look at it as well. So examples would be to implement clinical governance, advocating WHO's Global Patient Safety Challenge. And these are some of the things that, or the KPI, or the performance indicators that we look at: accuracy of patient identification, make sure the name, labeling, and so forth. Ensure the safety of transfusion, medication safety, clinical communication, and so forth and so forth. Again, so these are examples for the Patient Safety Council, which is here, right? So just the last one was actually for nursing. And again, there is actually, these are some of the results. So showing that by certain KPI, and you differentiate it by different states, which has patient fall, example, for patients fall. in the hospitals. So which state actually have the problem, which state will have highest problems of patient safety. So this is actually on public domain. So this is not something that I took from those. This is public domain. You can look at the website and look at it. So in conclusion, so I've touched on the clinical mechanisms. If anybody wants to have any questions, we can talk about it. So strategic purchasing is important. One of the main objectives is to ensure our universal health coverage is implemented through clinical mechanisms. Examples that has provided was CPGs, clinical pathways, audits, and also patient safety goals. And of course, value-based purchasing as well, which I talk about how health economics actually help in your clinical judgment and clinical mechanisms. Thank you. Any questions, anything? We still have like 5 minutes or 10 minutes.
Sorry, I have a question, but it's not from me. It's from participant in Zoom. From Ibu Nurul. I have question for Professor Chen. Is okay? Yeah, Professor Chen, I have a question.
Yeah, the session is for both of us. Yeah. Correct.
Oh, okay. Yeah, about the out of the pocket. See us how the strategy in China to reduce the out of the pocket. Meanwhile, many patients in the hospital, and you don't have gatekeeper to health service. How what the strategies to reduce the out of the pocket? Thank you.
I think it's a good question. I think because right now, I think the China's health policy would like to improve those kind of accessibility and equity. So those kind of are covered by the medical insurance. And so I think the medical insurance will pay much, and that's the part of the services, whatever inpatient service or outpatient services. So that's out of pocket, and so I think just decrease. So I think the medical insurance is the mainly that's the strategy, just try to protect our population. Mainly is for those kind of vulnerable population. Then if the out pocket is also significant amount, and I think in China, we have a lot of like a medical aid system. And then if kind of vulnerable population, they pay maybe out of pocket, maybe reaching to like 10,000 yuan, more than that. And then afterwards, and also the medical aid system or the other, we have a lot of like protect the poor people. They can give some additional payment and for those kind of things. So that's kind of just beyond the healthcare system and also society, and just supporting them. So I'm not sure. Yeah, answer your question. Thank you. Yeah.
Thank you for Professor Sarifah. In your experience, for what type of conditions you prefer to use adaptive HTA compared to the traditional one? Thank you.
I think in many countries, we are using adaptive rather than traditional, because when we talk about adaptive versus traditional, meaning that some of the areas that are very novice, meaning very new. So we have a horizon scanning, which is adaptive, meaning that we have to react as soon as anything comes up again. Example would be let's say the syndrome X, the hypothetical infectious disease, the new pandemic that's going to strike into Malaysia and so forth. So that is something which is imperative, meaning that it's imperative as well. We have to strike up some sort of decision beforehand. This is what they call as the horizon scanning, meaning that before the thing comes, they've already sort of look at a few options and how actually that we want to sort of face the problems. At this point in time, the traditional would be good for something that has already occurred or is occurring, and we can do like a cost effectiveness analysis or cost benefit analysis. You can do your modeling and so forth. But for preemptive mechanisms or preemptive diseases, I think the traditional does not probably works best. I think the strategic would be more better to equip countries, especially low income or middle income countries such as Malaysia and so forth, because we are not able to take the hit if the disease actually comes into Malaysia. I don't think that we are able to hit. So in a way, it comes into basic preemptive measures, and we have to prepare it from now. What's the best options to actually implement in regards to communicable disease, non-communicable disease, and so forth. So this is applicable throughout all sorts of activities that you do. Either it can be for maternal care, it can be for rehabilitations of patients for geriatric care, aging population, and so forth. And I think aging population has been mentioned many, many times, right? So we have to do something about that as well. Thank you.
Thank you. Okay, I have a question for Malaysia. So you mentioned that one of the kind of key goals would be to establish an internal office for strategic purchasing. So for systems like Malaysia that have a purchaser provide split, what would that, like, would it necessitate setting up some sort of like system where there is purchaser provider split, or can it be done in different ways in your opinion?
Yeah, in Malaysia currently, because we are very tax-based and there is only one single payer, which is the Ministry of Health, they are the provider, but they are also the purchaser at this point in time. But we are proposing for the National Healthcare Reform, where we are supposedly going into the National Healthcare Insurance. So when that happens, actually, we propose, or some of us propose, is that the strategic purchasing office or department or unit or whatever it is not handled by Ministry of Health. So that would be the purchasers provider split. At the moment, it is not implemented yet because we don't have the insurance in place yet. There have been suggestions that this unit will be placed directly under the Department of the President or the Prime Minister, meaning that it will not be under the covenant of the Ministry of Health to ensure this neutrality. How much the Ministry of Health are able to release its power, we don't really know, but this is what is proposed, so that they ensure that they are not being able to sort of haggle on that. They don't have a role in purchasing of services. What happens now, because they are the one purchasing and they are the one providing, there have been cases, and this is not something which is a secret. There are already national audit reports saying that the government has lost millions of dollars in drug leakages, millions of dollars of incubators that doesn't work, during COVID and things like that. And that has been pointed out by our national audit of the country. And that is also under public domain, meaning that, anybody interested can look at that. So that is the problem with being the purchaser, but you are also the provider. So you tend to actually, have your way. So that split will be introduced if Malaysia is to go into our reform. Thank you for the question. Yes. Siwei. Yeah. Together with Prof. Where is Prof?
Prof. Chen is in the back.
Yeah.
Yeah, maybe I want to ask both, from experience China and Malaysia, because Indonesia, like Prof. Laksono present before, that we have only one national insurance, which is BPJS. Yeah, we call it as BPJS. And sometimes in practical, it has many problems with us, Puskesmas, as a public health center, and also with health office, regional health office, because sometimes BPJS, because they are the only one, so they becoming like selfish lives, that they do not like to set the data, and then they like to sometimes making some policies, not talking to us before or not discussing, and yeah, that's why that's the only national insurance. And how about Malaysia and China? Maybe you can say what is actually the best purchaser for the national? Is it better for three like Thailand, or just one, but good governance like that?
Yeah, we don't have, Malaysia does not have an insurance yet, but coming from other countries as well, I foresee that if Malaysia goes into national health insurance, this provider and purchaser split must be there. If not, this is what happens again. Once any complaints goes up, actually, the person who is in charge might not actually look into detail, or might actually forgo some of the, activities, or because they are the one at fault. So you must have another body that actually can or can actually dictate, or comment or give audit or things like that. This is like an external audit, an external auditor that actually does that. So if you are the same one it usually it goes down the drain that nobody takes effort after that. Yeah. Yeah. Yeah.
I think all the speakers always talk about strategic purchasing. So it doesn't matter who purchases, it's the system and the accountability. Like in Taiwan, I think the group also discussed, you have the National Insurance Agency, right? They do the purchasing because they do it's a single payer system, so they purchase from all the total. So it tends to be a more efficient system because you have a pooling. But the problem is, of course, how do they actually purchase, right? And what are the parameters? That's why purchasing, I think Professor Lakso also talked about it, in terms of how you do it, the accountability systems, and what do you actually purchase, and how do you purchase? So Taiwan, the problem, of course, is the payment mechanism, right? So they don't purchase the integrated product, and you purchase, that's why your healthcare is fragmented. So when you have a fragmented system, it's inefficient. You have a lot of, the quality cannot be good because people can go from place to place. And Professor Chen also talked about in China, they have an insurance agency, right? But then you have all these hospitals and the clinics, they run independently. So that's why we talk about and we're keen to look at really one of the things they must look at ultimately is to buy that integrated care for the patients, not episodic care. This is what's happening with many of the agencies, even though they're accountable, but they don't have that mechanism in terms of determining what is the product they should be buying, right? So it's the product they should be buying that's important, and how do you arrive at that product? So that's the element of strategic purchasing that we should be looking at. Really, you should be looking at what the problem of the system is. Your system has a lot of problems because your population health needs are there, but how do you all design the system to meet the healthcare needs? And you cannot do it by our systems at the moment. And that's why we advocating that our systems are not fit for purpose. And if you're not fit for purpose, then you're buying things which are not fit for purpose. So you need to do the right things, right in the right way. Right?
Yeah, so I think governance must be there as well. Yeah, audits and governance. All right, thank you.
Actually, echo to Professor Yao's point about like Taiwan's purchasing. I would say that I can offer another like lesson of Taiwan's like healthcare purchasing regarding like drugs. So NHI is like the single payer, and it is like the practice is it is surveying the like market across like different pharmaceutical companies to determine like how much amount the NHI will do reimbursement regarding certain drugs. Then when the doctors like issue that drugs to the patients, then the doctors get reimbursement from the NHI. So because the doctors in Taiwan, like the hospital system, health workers cannot like get enough income from the global budget system. So one way they try to like generate extra income is actually to utilize the differentiated price difference between the reimbursement they received from the NHI regarding drugs and the drug they purchase from the pharmaceutical companies. That price difference become part of the income for the hospitals. So for the hospitals, they have in the current system, they have the incentive to look for like to negotiate lower from the pharmaceutical companies, so they can get a bigger price difference. They can get bigger income, which then lead to the pharmaceutical companies to lower their price, which in turn leads to NHI. When they survey the market, they found that, oh, pharmaceuticals are lowering their price. So their reimbursement rate is keep decreasing. So there's a saying that there's a black hole of drug reimbursement and drug income in Taiwan. So this is kind of a typical like institutionalized incentive to lead to the unsustainable like market of drugs, which eventually bring negative impact to patients, because international pharmaceutical companies will find that Taiwan's market is not profitable, so they will just exit. So this is a lesson that to other peers to think about this issue.
Thank you for the comments and thanks Professor Chen and Professor Wen Putit. So we now come to the tea time. We have prepared some pie and tart outside, and then we will come back in 4:15 for the last sessions by Maria, and then we'll have the group discussions. Okay, so enjoy the tea outside.
Recording stopped. Recording in progress.
I'm waiting for people to sit down. I'm waiting for people to sit down. Okay. I am all that stands between you and your group work, so let's get this done. Okay, this is your session on information and engagement and social franchising. I'm Professor Maya Baltazar Herrera. I know it says Maria Elena, but that's way too long. So please just call me Maya. Okay. I just want you to see where in the framework we are in right now. So I am giving you the last two bullets of the policy instruments. So these are the policy instruments of exhortation and information and social franchising. I'm showing this to you because I want you to see the words we're using. We're using information, engagement, and exhortation. Okay. Social franchising is its own different thing. The other thing I wanted to show you, and I think it's important to think about it now because we've been talking about the resilience of health systems. And we've also really been talking about the process of implementing all of these interventions. Because this looks like a table and it looks linear, but in real life, this is a cycle. Because it never stops. Our work never stops. Okay? And we tend to think of the generic cycle as this bit, where at the center is who we are, our vision, our mission, our purpose. And the endings, the cycle is always where are we right now? Situation analysis. Where do we want to go? How can we get there? Strategy. How do we actually do it? Implementation plan, as Professor Ike was talking about. How are we doing? Monitoring and evaluation, which actually brings us back to, well, where are we right now? And we cycle back. This is what we're doing all the time. If you look at the framework we're using, assessment is PSHA. And this is what Prof. Shita started out with this morning. Where do we want to go? Priority objectives. Specifically to this program, we're talking about what are our objectives in terms of PSE? What are objectives in terms of integration? But remember always that PSE and integration are a means to the end for health system outcomes. So we don't pursue integration just for the purpose of integration. We pursue integration so that we are able to increase our health outcomes. Strategies within our framework. What is the level of the intervention? Is it at the macro level, at the meso level, at the micro level? I think most of the professors will say, and all of you will probably say, most of our interventions tend to have something at every level, sometimes more focused on meso, a little bit here, sometimes more focused on micro. I think very few national level interventions are single level. So at what level are you intervening? What modalities of integration are you looking at? What mechanisms within each modality are you using? And which policy instruments are you using? So right now, in this session, we're going to talk about the policy instrument called information and exhortation and social franchising. So we're going to talk about implementation, monitoring and evaluation. I put in, you notice I put in trigger events. And the reason I put in trigger events, so one of the reasons we do monitoring and evaluation is so that we are able to stop and say something has changed. We need to do something right now. So if we go back to 2020, January, February, depending on which country you are, in our case, it was March, something happened. If you're not constantly monitoring, you will not know it's time to get something done until might be a little late. Not too late, but still. Okay. Definitions. Information. Information is facts provided or learned about something or someone. Okay. How do we use information? Exhortation. Communication emphatically urging someone to do something. Engagement, the act of engaging or being engaged. So you notice that engagement is one step forward. Okay? And what do we mean by engage? We occupy or attract someone's interest or attention. so that they will participate or become involved in. And this is, I think, an important definition because we're talking today, well, these last 3 days, about private sector participation. Okay. So within our framework, when we talk about information and exhortation or information and engagement, what do we mean? We mean the policy instruments that are aimed at changing beliefs, attitudes, and behaviors of actors within the health system. In management, we call this social marketing. So essentially using the tools of marketing in order to achieve social goods or public goods. Are we okay so far? Okay, cool. I will give you a quiz later. I want you to remember this. So all of our interventions are about creating change, right? When we create change, there are normally, PK will get so angry with me, but 3 things we change. Hardware. So all of the tangible stuff, hospitals, right? We need money, equipment. Software. What's more difficult, hardware or software? Systems, processes. Software is harder, right? Hardware you buy, software. Third, liveware, people. Which is the hardest? Hardware, software, or liveware? Liveware. Why? Because people have brains.
And emotion.
Right? They have brains, they have feelings, they don't necessarily do what you want them to do. Sometimes even when it's good for them. Okay, so social marketing is all about the toughest part of change. People. Okay, why did I tell you this? Because there are always 3 levels of resistance to change. And a lot of social marketing revolves around how do we address those 3 resistances. Does anyone know what the levels of resistance to change are? What's the first? No? No one? Yes? They'll get there. But remember, 3 levels of resistance. Okay. I want you, this is a surprise. I will tell you the resistance to change. Anyway, back to regular programming. Our learning objectives, we want to understand the rationale for using information and engagement instruments. We want to be able to develop information and engagement objectives. We want to understand the key components of a social marketing plan. And then, because we're also doing social franchising, we want to understand the rationale for social franchising and the components of creating a social franchise. What do we cover? We're going to just talk about information and engagement concepts. We're going to talk about the rationale and limitations of social marketing. It's powerful, but it is not a cure-all. How do we develop a social marketing mix? How do we develop a social marketing plan? And then social franchising, we talk about what it is, the rationale, and what are the steps in developing a social franchise. Okay. So social marketing. What are the potential uses of social marketing? As we said, the purpose is the adoption of a product, service, or behavior change, right? So, which usually includes changing beliefs and attitudes. So you notice I have 2 categories here. 1, within the framework, especially of this course, we can use social marketing to support the adoption of enabling behaviors to support implementation of other policy instruments. So for example, we want to do strategic purchasing, right? What should we do in order to make providers amenable to engage in a strategic purchasing contract with us? That's social marketing. What do we do in order to get policymakers to agree that we should get involved in strategic purchasing, especially if you're in a country where the providers are very powerful in terms of influencing policymakers? So that's part of social marketing. So it will include increase the willingness of providers to enter into strategic purchasing agreements, as I said, encourage the self-employed to contribute to social health insurance schemes. When we look at social health insurance schemes, always the easiest is employed individuals. Why? Because we can mandate employers to contribute. The next easiest is indigents. Why? Because the government will pay. The toughest is Some of the people in this room, doctors, lawyers, self-employed individuals, they are the hardest. So you use social marketing to encourage them to contribute. That's social marketing. So you can use it, and what's that tool? That's the financing tool. Encourage healthcare providers to undergo accreditation. Just because you build it doesn't mean they will come. It's also social marketing. Encourage patients to ask for generic alternatives. I'm sure you have found in some countries, even though it's cheaper, they don't buy it. Why? One is access, it's not available. But second, they're afraid of the quality. It's not that it's actually bad quality, it's actually safe. They are afraid. Right? I don't know this brand. It's not pretty. Right? The branded is colored, it's plastic. So they're scared. Social marketing. The second use of social marketing is really just the direct use of social marketing, not in support of something else, but in and of itself as an instrument to achieve a specific social goal. So increase willingness to follow clinical guidelines and pathways. So if you're using the modality of clinical integration, how do we get physicians follow? Encourage individuals to choose and maintain a long-term relationship with a primary care physician. I think this is the question of the moment for a lot of us. How do we encourage them to do this? Because you can't just mandate, right? Even if you mandate, they're not necessarily going to. Encourage healthcare professionals to practice in rural areas. This is a question for us. 7,000 islands. I always tell myself I cannot get too unhappy because Indonesia has 14,000. So we have double our problems. Even in terms of people, more than double. Also encourage specialists or tertiary hospitals to refer non-acute patients downwards. Because once they have them there, especially private hospitals, that's money. I mean, why am I gonna send them away? That's money, right? So all of this just directly social marketing, not in support of an instrument. So I just wanted to think of social marketing in both those ways. Okay. Social marketing is especially appropriate when there are multiple decision makers, okay? And especially when they're involved in mass markets. And the objective is a degree of self-sustaining market equilibrium. Okay? So it's really managing those beliefs and behaviors so you create a new equilibrium. I want you to remember the word equilibrium because I always say this in social marketing. When a situation exists and has existed for a long time, there is a reason for it. The status quo is the status quo for a reason. That is why the system is at equilibrium. You need to figure out what keeps it in equilibrium and disturb it. And then you need to create a fresh equilibrium so that you maintain the change. So that is always our goal in social marketing, not just to provoke a trial change, to institutionalize a new equilibrium of change. And the thing with health systems, it's because it's multiple actors, you want them to change together. So you need to understand the interaction of how the different actors work, how the different levers work. So this is why EK was saying it's very important that you understand the causal mechanisms. That's very important in social marketing. Okay? So often the social marketing exercise will point to the need to employ other policy instruments. So in the same way, social marketing is used to support the other policy instruments. Sometimes the other policy instruments are needed to support social marketing. For example, sometimes we need to use short-term or long-term some level of incentive, like subsidies or vouchers, in order to provoke a change. Okay. So a little more about social marketing. As I said, it's about using the tools of commercial marketing to change beliefs, attitudes, and behaviors to achieve a social good. How do we do this? Step 1, identify the desired behavior change necessary to achieve the objective. Always remember, we're changing behavior for a purpose. What's the purpose? What's the behavior? And let's be clear that we understand why that behavior will lead to the change. Okay, so whose behavior, who's the audience, very, very important. What is the change? Step 1. Step 2, understand the reasons for the current behavior. The status quo is the status quo for a reason. What is creating the current equilibrium? Normally, that there's a feedback loop. that institutionalizes the current status quo? Are there other factors or influencers driving current behavior? Are there conditions or factors affecting current behavior? Because it might not just be a matter of giving them a message. It might be a matter of example. This is not health. People litter. We keep telling them, do not litter. But there's no trash can. What do you want me to do? You want me to put my trash in my pocket? I have a small pocket. So sometimes what you need to do is change the environment, not just the message. Okay? You need to understand it. And then you can develop a plan. Cannot develop a plan unless you understand the problem fully. Okay? Because it's not always just what they think. And this is the problem with thinking social marketing is nothing but information dissemination. Okay. Have you figured out what the first level of resistance is? The first level of resistance to change is I don't get it. I do not understand why I need to change. And this is why many people think social marketing as a matter of sending the correct message. Because that is in fact an important part of creating change. You want them to get it. Why do I need to do it? Why? Okay. The first level of resistance is I don't get it. And information is important, but it's almost never enough if it's just that. Okay. So to understand this, we dive into a little bit psychology. What are the roots of behavior? I always think this. Want people to change behavior. First level, don't get it. Explain it to me. I don't like it. It's too hard. Make me want it enough. And then maybe I'll do it. Okay? So most social marketing people think this way. So it's not just explain that it makes sense, make them want it. And then make it easy to do. Put trash cans. Some examples. We want people to take mammograms, cancer screening. What's our message? Early detection of cancer improves likelihood of remission or recovery. Want people to stop smoking? Cigarette smoking is hazardous. It gives you cancer. Right? We want people to family planning. Right? Planned babies are better cared for than accidental babies. That's the message. Now let's criticize these messages. What should we ask? Are these things important enough to create motivation? Does it appeal to the values of your audience? Okay? Is this information relevant to their current way of thinking? Is this even the problem? One of the things you need to do is check competing emotions. A lot of people don't go screen, even though they know it's important, they don't want to know they have cancer. It's like if they don't get tested and they don't know if they don't have it. Fear. Where is that fear coming from? You could get cancer. Yeah, I'm 25 years old. What's the likelihood I'll get cancer? They look at the numbers and they go, it won't happen to you. All of us know that human being who's 75 and has been smoking since he was 15 and is hale and heart. All of us know someone 45 years old who never smoked a day in his life who died of lung cancer. And it's easy to trot out what we call that anecdotal data. But if it's not for sure, especially if you're young, and cigarette smoking makes you look cool, gives you access to the bosses. This was how I started smoking again when I started working, because all of the influencers and bosses smoke. I want to know what's happening. I want to influence them. I go to the smoking area. But you know, the other thing that works for people, something sure. You smoke, you get wrinkles. 100%. It's not like cancer. Cancer may be. You smoke, you get yellow teeth. You smell bad. 100%. Well, you're young. More powerful message, yeah? Know your audience. What will affect one human being will not be meaningful to another person. That's why it's so important to know your audience. Land babies are better cared for. Well, that's not my problem. Contraception is a sin. I will go to hell. God will provide. Look at the lilies of the field. That is a literal quote from the Bible, by the way. My country, children are a gift. My family will help me. So this message, that's irrelevant. Or contraceptives are expensive, hard to find, and embarrassing to buy. So you need to figure out what the real problem is so you can solve it. I'm not going to talk about the Catholic Church in the Philippines and how to solve the contraception is a sin, because that's an extra 2 hours. You need alcohol to drink to do that, or at least lots of coffee, something. So you can find a message that might be better. Like, early stage cancers, few side effects, more effective, cheaper, and your children really need their father and mother. Look at your risk factors. Maybe kind of twist the message a little bit. So if they can begin to think, if my personal profile puts me at risk for this cancer, I can do something early to avoid all the negative consequences, including the I will feel bad, etc. Cigarette smoking gives you wrinkles. So I want to be beautiful and young forever. For young women, she's laughing so hard because it's true. Okay. With the church, usually you try to find other influencers. At the height of the reproductive health debate in the Philippines, I was riding a taxi. I talked to the taxi driver. I said, so what do you think about family planning? He said, I practice it, ma'am. Aren't you Catholic? Ma'am, those priests, I don't believe them. In Tagalog, he said, hindi man lang napuputikan paa nila. In English, that means they have never stepped in mud. But there are nuns that go to our neighborhood and they say, personal conscience. Support it. So even within a system, you can find people to carry your message. Which is, so I gave you the first level of resistance. I don't get it. I don't like it. There is a third level, and it's not this. It's not how do we enable. I don't like you. I don't like the person sending me the message. So priest, nun, I like the nun. I don't believe the nun. It's also important to figure out who is sending the message. Having said that, I assure you that is not enough, because there are not enough nuns that think that way. Okay. So for the other bit, it's embarrassing. What are the other aspects of marketing? Lower the cost, improve availability. That's our problem with generics, right? Improve availability. Make contraceptive use socially acceptable. Make it cool. Okay? And I'm sure you've seen all of the advertising that makes contraceptive use cool and acceptable. Okay? So we need to figure out what message we need, and that really depends on current thinking and who the audience is. Okay. Okay. So step one is really having a clear understanding of what you need to fix. And then you can create your plan. It's the plan. What are we selling? What are the elements of the behavior change? Who is your audience? How can you make it more attractive? What are the benefits that they value? What are the pain points that make sense for them? So what's the negative message that will hit them? What's the positive message that's beneficial to them? How can you make it more attractive? Price. What is the cost of adopting the behavior change? And remember, this is not just money. It is convenience, foregone pleasure, the foregone pleasure of smoking or drinking. Social risk. Okay. So you need to understand what is acceptable to your audience, because the decision to change is always benefits versus costs. Promotion. This is not just messaging or advertising. It includes public relations. It includes events and other activations. It includes special offers, incentives, as I said earlier, vouchers, subsidies. Okay. And which channels and locations? Social media, Is your country a TikTok country, a Facebook country, an Instagram country? All of the above. Yeah, when our Minister of Health started doing stuff on TikTok, I did not know what to feel. Okay, please, where do you need the change to occur? And this is important because you need to figure out whether the environment itself, the environment needs to change. Okay? What can you do to motivate the change? Is there a service or tangible product that must be made available in order for the change to happen? So for example, I want them to have mammograms. Well, how many places can they have mammograms in that village? None. Where and how? So you notice if you want to create a change, you have to look at everything. There are 4 more. Because it's social marketing, 4 more P's. Publics. Who are the other actors involved? How do they influence parent behavior? Because social problems are complex and wicked. It is almost never a single audience. It is almost always multiple actors. So who else are they? Partnerships. Who do we need to work with? Who can we work with? Who will be willing? Policy. How do we institutionalize the change? We need to have regulations, we have accreditation, something. First things, what resources are needed? So not just money. All the resources, what resources do we need? What's available? What can be made available? Where are the resources coming from? Can we find other people that help us with this? Is why those 2 things, partnerships and first things, are kind of related. How do we make the system sustainable? My question always for first strings and resources is how do we make this sustainable? So much of our programs are donor dependent. The problem with donor dependence is donor fatigue. After 10 years of funding the same thing, they go, you still need money. So, and this is why when we look at social behavior, social change, we're looking for a new equilibrium. At some point, we need to be able to institutionalize the change. It shouldn't need endless new resources. We're looking at sustainability. Okay. How do we work the marketing mix? We change behavior through changing mindset, providing better information, delivering information from an audience-focused point of view, enhancing perceived benefits. So message is important, what defines value, improving the products. Remember birth control, lower those pills. Decreasing total perceived cost, interventions to decrease price, interventions to increase availability. So you work the marketing mix in this way. So some examples, I wanted to put in things with the commodity because that's where you see like larger systems. So enhancing the perceived net value, interventions to increase demand for commercial volumes, interventions to establish or strengthen supply chain. So I guess one of the easier things would be to think of contraceptives. Because in order for a family planning program to work, you need lots of demand and lots of supply. Okay? And typically what you want to do then is you want to have both supply-led interventions and demand-led interventions. It's almost never just one. Okay? So you can have interventions to establish or strengthen the supply chain, temporary support to demand. Please don't make it forever support to the manufacturer because then we will get donor fatigue again. Okay? So it's typically temporary support to manufacturers, distributors, and then increase players and then make it profitable because there is demand. And then we can go, hey, this market exists. So for a lot of these things, what we're doing is we're creating markets that are vibrant and self-sustaining. So if there's continuous demand, there will be continuous supply. They make money, everyone is happy. And we are happy. Okay? Supporting programs, price control. So we have demand side interventions. Important to figure out the target population. Important to understand what are the constraints to demand. So in the Philippines, family planning, the Catholic Church. Great for us. Supply side interventions. Is it a well-defined product? How can you sell use of the product? What is the personal benefit for using that product? How do you socially acceptable, etc. Potential producers. What is an optical? This is important. If you want to do social marketing, that includes products. If you want to do any sort of, in fact, if you want to do any intervention with private suppliers, private sector. The one thing you need to understand is this. The private sector responds to profits. If there is a profit to be made, the private sector is there. If all you will tell me is, it's good for the country, that's your job. I pay taxes so that you do your job. You want the private sector to be present, give them a profit. So a lot of what we do is creating markets that are vibrant and self-sufficient. So we need to know what is the optimal scale of production so they still make money. What are the constraints to production? Then we can have our power, use our power, right? Then potential retail outlets, not necessarily traditional outlets. So in the Philippines, we have micro pharmacies that are generics only. So only generic, nothing brand. Advantage, it's cheap. Advantage, it's very near their house. But you know, the only way it worked was we needed to create branded generics. We had to convince the two largest local manufacturers to come out with a generic brand and to sink money into advertising. It's just as good. And they paid a lot of money to very popular actors and actresses because they need to like the influence. So you can create new methods. Side note, you can also think of the private sector engagement in implementing social marketing. So I just made your life more difficult. Private sector providers, private sector insurers, also private sector marketing people can help you develop really effective marketing campaigns. Why? Social marketing is complex and multi-phased. Private sector players typically have better expertise than we do in the public sector in terms of marketing. Okay, so they provide expertise, reach, efficiency. Okay, so how do you get the private sector to participate? One, commercial transaction, pay them. We don't like that. Second, philanthropy. Especially in countries where donations are tax deductible. Or corporate social responsibility. Find an industry that is near to whatever it is you're selling. So if it's water, for example, what industry? Beverage. Coca-Cola. Okay. So how do we develop a social marketing campaign? Clarify the health system goal. Understand the current situation, what drives the status quo. Develop the strategy. So essentially work that cycle. Again, clarify the social marketing goal. Who's the target audience? What behavior we're aiming to change? Truly understand the target audience. Identify the evaluation measures. How will we measure the behavior change? What else should we measure? Like, before we get to that behavior change, what else needs to happen? What can you do to do the evaluation? You can do force field analysis. What's the helping force? What's the hindering force? You identify key players. You develop alternatives for institutionalizing the change. How do you create it to review? Evaluate resources. Design the components of the plan. So 8 Ps. Develop an implementation plan with timeline, accountabilities, and monitoring. We'll talk about implementation more tomorrow. And then we develop a plan for refining using the monitoring information. Okay? Okay. Social franchising. What is social franchising? Like social marketing, it's the application of commercial franchising concepts and mechanisms to achieve a social. Do we understand what social franchising is? So essentially, you have a franchisor who has a model that can be replicated, a successful model that can be replicated. Okay? So for the franchisor, what is the advantage of having franchises? You can extend the reach of your social marketing or of your social program. Also, you can utilize the resources of the franchisees to achieve your goals and to extend your reach. You enhance the value of the franchisor brand and reputation if you choose your franchises well and they are successful. You can learn from the experience and ideas of franchisees because they maybe have better local understanding, and you can leverage it system-wide. One franchisee does something good, you can leverage it. What are the downsides? Loss of control. You don't know if they will follow you. You need to develop a system to audit and control, because managing other people is different from managing people who report you. You need to provide franchisee support, training, etc. Potential reputational, legal, and financial risk if there is franchisee misbehavior. Okay. So if you're going to run a franchise, it's important that you have a system for managing that franchise. So there's always pros and cons. For the franchisee, the most important thing is you benefit from the first two. You benefit from the franchisor's brand and reputation. So the I like you, so you borrow their credibility, and you have access to their knowledge, their systems, and ongoing support. So if it is, for example, pharmacy, a supply of commodities, it will include training, advertising, public relations. Essentially, for the franchisee, it's like a business in a box, social enterprise in a box. Okay, decrease risk and time for startup. The downside is the cost of the franchise. Typically, there is some cost to the franchisor. Loss of control, because you have to follow the rules, limited flexibility, and if, conversely, something happens to the franchisor's reputation, which you are borrowing, it affects. Okay, how do you design a social franchise? Number one, how do you create sustainability? The most important thing in a social franchise is the social enterprise model. The model for the one unit that is sustainable, because that is what you're selling. I can replicate this granular model. You can run it, it works. I promise you it works. That's the most important part of a social franchise. So a granular model that works. Okay. Question, when I say social enterprise, if the entity makes a profit, is it still a social enterprise? I don't know if you have no feelings or you're tired. I will give you the management answer. The current research says this. It doesn't matter. It can be non-profit. It can be for-profit. As long as the purpose is a social good, it is a social enterprise. The important thing, though, is even if it's non-profit, it must be sustainable. It cannot be reliant on donor funds. It's the important thing. Okay? So that important one is develop the model for a single unit of the enterprise, because that is your model franchise. That's what you're selling. What's the market? What's the offering? What are the delivery mechanisms? Where are the required resources? How do you create both financial and social sustainability? Social sustainability is acceptance of society, so that suppliers will be there, that customers will buy. Develop the elements of the franchise contract itself. Develop the mechanisms necessary to operate franchising operations. As I said, what are the activities? What are the processes? What are the structures? You have to create an actual franchise staff. They are the ones that will support the franchisees. What is the funding for franchise operations? So all of that, essentially you create a superstructure to manage it. Okay. I have 1 minute left. Final thoughts. Trying to create behavioral change. Remember, the status quo is the status quo for a reason. Until you understand what's creating this equilibrium, you cannot create a new one. Changing behavior requires changing the conditions and factors that support the current equilibrium of behavior. It's not just a matter of messaging. Success in social marketing aims for a new equilibrium of behavior. So you need to create something that has a feedback loop that sustains the fresh behavior. Okay? And social change comes to people. One of my favorite quotes on social change by Paul Watson, which is why it's both the most rewarding as well as one of the most difficult things you can do. We have time for one question.
Yes, first, thank you for the interesting presentation. My question is that in Indonesia, we have a superstition, or I would like to call it pamali. So one of the pamali I know is if a pregnant woman eats a pineapple, she will have miscarriage. But the problem is that if they believe that family or superstition, they will the tendency is that they will never think about the medical aspect. For example, there is a pregnant woman told by the mother that you will have miscarriage if you eat pineapple. Then the pregnant woman asks, why do I get miscarriage if I eat pineapple? But the mother just say, because you will have miscarriage. So I don't know why, but at all costs, don't eat pineapple when you're pregnant. So how do you deal with it? Is there any recommendation? Thank you.
This specific problem, my recommendation is don't worry about it. Nothing bad will happen to a pregnant woman if she does not eat pineapples, correct? You don't want to eat pineapples, that's okay. Eat oranges, eat apples, it doesn't matter. When your problem with superstition is when superstition makes people do things that are bad for them. But not eating pineapples is not bad for them. So I think that we have to choose our battles. Yeah, choose your battles wisely. That I think maybe is not a battle you want to fight. What you want to do is say, well, if you don't want to eat pineapples, here are other sources of fiber and vitamins. I would not fight that battle.
In your experience, what is the most challenging to improve the equilibrium?
Depends on what the problem is. When you talk about what is the hardest to create the new equilibrium, it really depends on what is the anchor for the current equilibrium. Okay, so in the battle that's closest to my heart, which is reproductive health, I think the real challenge is kind of your superstition. The battle is religion. The battle is separation of church and state. The battle is to be able to tell the Filipino people that even in the Vatican, that is not canon. But it is the Catholic Church is very powerful. So that is a long drawn out battle. And until we get to the point where, I'll tell you the specific problem that we have. In our country, those who are truly religious, we believe our priests unquestionable. It is a sin to question them even when they're doing bad things. You know, this is the church that found out that there were pedophiles in its ranks and decided to export them to other countries so they would not be put in jail. So that is a terrible problem. And until we get our citizens to stop treating the priests like they were God, can't fix that. I think it's going to require an entire generation of more educated people. That's it. So there are some that are easy. For example, breastfeeding. But it was just 2 decades ago when we were trying to get people to breastfeed, right? And now it's a big deal. People are making money from teaching people how to breastfeed. How did we fix that? Number one, we convinced people that breastfeeding is actually better. Number two, we made it cool to breastfeed. That was where we broke everything. We made it so cool to breastfeed. Like people were going on Instagram, breastfeeding. We also mandated, we also made it easy. We required every commercial place have what? Breastfeeding areas everywhere. But but that for breastfeeding, it was that. We made it cool to breastfeed. Because I think 15 to 20 years old, it's better for the child. It's better for the child. Like, they wanted to, but it wasn't cool. When it became cool, it wasn't just people were doing it, but it became a passion. Every single person I know who's pregnant for the first time, that is a major item on the agenda. How do I, correct? It's a major item on the agenda because it's cool. It's cool. I am a superwoman. I am powerful. I have a career, but I guess you need to make it cool. Yes, ma'am.
Of the COVID-19, right? Many fake news, many people just create something that it, then so any in that you case that you found that you use this social marketing, yeah, you know that because during the COVID-19 situation that, so you should clean that, you should use that in order to kill that disease or whatsoever. So in that, I think that in that case, can the social marketing be influenced or influence on the case of the COVID-19?
In the case of COVID-19, policy was important. So making masking mandatory was important. In our country, we actually made face shields mandatory. Like, step one is to get the authorities to believe you. Step two, and I think generally in the countries where it was countries were very successful was single voice. If there is a single voice from the public sector, from all of the public sector, not just the Ministry of Health, everyone, the Ministry of Trade, the Ministry of Health, the Ministry of Education, one voice. If the private sector, one voice. If there is, and this happened multiple times in our country, when there's the ivermectin problem, public letters from the Philippine Medical Association, from the Philippine Association of Microbiologists, from the Philippine Association of Epidemiologists, there were public letters. Not only were there public letters, they organized press conferences. They organized public Zoom meetings. They were on Facebook, they were on TikTok, they were on Instagram, they were talking to the press, they were talking on radio, single voice, single message. Drown out the competition. Use because the power comes from people who are experts. So if you get the experts and you get the cool boys, the pretty women and men who are actors and actresses that people listen to, one voice, single message. That's typically what you want to do. But again, not just messaging. In the case of COVID, policy. With one voice. In the Philippines, that was very, very effective when we had problems. And also, it helped that there were public posts. So if I had a problem, I had a friend who was saying something wrong, I would actually say fake news. In fact, here's the letter from the Philippine Medical Association. And if you don't want to believe me, go to their site. Go to the site of the Society of Microbiologists, the Society of Epidemiologists. Go to their site. So it's really making sure that that message is clear. And they were always like one page. They're clear, then unequivocal, they come from the experts, they're verifiable. Lots of infographics. Yes. Yeah, those policies are very important. The other thing we were doing was we actually said, so we had strict, and then if you did something good, we gave you incentive. So if you put in stay safe, then you could have like 50%. You have good ventilation, instead of 30% occupancy, you could have 50% occupancy. So we used mandatories and incentives. So if you use all of the tools, the more tools, the better. But I think in terms of messaging, one voice is very important. And time's up.
Yeah, thank you, Maya. Thank you. So it comes to the last session today for the group discussions. Yesterday you talked about the gaps, challenge, of the countries that or regions that you are going to study. And then today you're going to discuss about the options or any strategies that can address the problems or the gaps that you identified yesterday. And please apply what you learned today, like the policy tools about the regulations, purchasing, or even just Maya said about the information exploitations or social franchising, etc., and to address the problem that you have identified yesterday. So it's your time now for the good discussions. Thank you. And then this session will end at 6 p.m.
Recording stopped.
Halo, selamat sore. Untuk Pak Groko, Bu Lucy, Bu Nurlayla, dan Bu Nurul, apakah bisa join untuk breakout room? Halo, selamat sore Bapak Ibu. Apakah sudah selesai diskusi semua? Mungkin dari kelompok 1 apakah bisa ditampilkan atau disampaikan hasil diskusinya yang tadi? Mungkin perwakilan saja, mungkin Dr. Zikri atau yang lainnya dari kelompok 1, apakah bisa disampaikan?
Jadi selamat sore semuanya. Ketemu lagi, itu jangan bosan sama saya dalam beberapa hari ke depan. Sudah saya juga di dalam lagi diskusi dan lagi bingung juga gimana caranya mengaddress challenges karena yang kelompok saya kebetulan Singapura kayak semuanya udah bagus tapi memang ada beberapa challenge yang berat. Mungkin ada yang mau diklarifikasi atau ditanyakan dari kelompok 1, 2, 3, dan 4? Kok yang masih ada di sini? Oke, kalau misalnya nggak ada, kita lanjut besok aja mungkin ya. Dari Mbak Nila atau Mbak Ikasul mungkin ada mau sharing di apa namanya breakout room challenges-nya apa yang didiskusikan.
Mungkin karena kalau misalnya tantangannya mungkin ada yang join breakout Zoom-nya tuh lama, jadinya tuh saling tunggu gitu loh. Mungkin nanti kalau bisa, kalau sudah waktunya diskusi itu stay di laptop kayak gitu. Jadi teman-temannya tidak menunggu seperti itu sih. Terus kemudian mungkin nanti bisa, kalau misalnya diskusi tuh bisa share screen kayak gitu. Jadinya nggak nggak ngawang kayak gitulah. Gitu
Oh,
aja.
oke. Tadi akses share screen-nya nggak dibuka ya?
Oh, dibuka. Tadi
Oh,
kelompok 1 bisa share screen.
oh ya, oke. Oke, then.
Mungkin dari peserta ada yang ingin disampaikan.
Izin bertanya, Dok.
Ya.
Untuk hasil diskusi ini kita diskusikannya itu kapan ya?
Besok dipresentasikan. Nah, ini kita juga lagi koordinasi. Kalau dari kami yang mengarrange Zoom meeting ini berharapnya Prof. Laksono sebagai narasumber bisa memberi masukan langsung ya. Besok jam berapa ya?
Baik.
Iya. Tapi misalnya ada apa ya? Misalnya Bapak Ibu sedang mengerjakan di Google Drive gitu. Kemarin ngerjain di Google Drive ya, Mbak Nila ya? Atau di tempat yang sama atau di Google Drive yang berbeda mungkin bisa
Di
di-share dulu kepada
Google Docs.
Yang sama.
ya, yang udah dikirim Mbak Nila ya. Oh, oke then. Ya,
Sudah
udah
dikirimkan.
sih. Iya, jadi besok sebentar ya. Jadwalnya adalah
Besok itu untuk
presentasi itu lebih cepat kok harusnya. Kok nggak ada? Oh, ini hari ketiga.
jam 3.
Iya, oke.
Sampai jam
Itu kan 15.45.
Grab summary dari jam 1, Dok.
Gimana? Jam 1 overall discussion on challenge. Oh ya, group summary and discussion. Oke. Dari jam 1 siang ya. Ya.
Jam 1 mungkin bisa
Tadi dari jam 1 siang. Ya, oke. Ya, nanti kita koordinasi ya karena besok kan ada acaranya Prof Yudi. Setelah ini kita koordinasi dulu. Jadi nanti dipresentasikan jam 1. Waktunya pendek aja sih. Ada 5 kelompok, 1 kelompok 10 menit aja maksimal. Lebih pendek lebih bagus. Terus sisanya untuk diskusi. Mungkin sebelum ditutup ada yang mau diklarifikasi, mungkin ada mau diskusi bersama, sama-sama bingung maksudnya. Oke, kalau nggak ada, udah sore juga ya, udah sore banget di sana. Udah ambil malam di sini. Terima kasih semuanya atas partisipasinya. Apabila ada yang mau didiskusikan, ada yang mau dikritisi, silakan bisa didiskusikan di grup ANHSS. Di situ ada Pak Muk juga dan ada Pak Laksono yang memantau. Terima kasih semuanya atas partisipasinya. Selamat sore, selamat sore menjelang maghrib. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam, Bu Lika.
Terima kasih. Terima kasih,
Dadah,
Dok.
live dulu ya. Amin.
Ya.
Terima kasih untuk partisipasinya. Semangat.
Live ya, Bu.